Just remind members that all committee meetings are held in public session and are recorded, and that all mobile phones and Blackberries interfere with the recording equipment. And can I ask members to ensure that there are any mobiles they have are switched off? Okay. Move on to item number 1 then is apologies. We have apologies from our chair, Maeve McLaughlin, who can't make it today. I think we have everyone else present. Fergal, I think, is just nipped out and will be back in again. Is that correct? Yep, everyone else is here. Yep. Okay, chairperson's business, item number 2. There is none as the chairperson is not here, so that will be, she'll come back with it all being well next week. We move on then to item number 3, which is the draft minutes of the meeting on Wednesday the 10th of December 2014. Can I refer members to the minutes which are on page 6, and can I ask, are members content with the minutes?
Right.
Thank you, members. Move on to item number 4, which is the Food Hygiene Rating Bill briefing from the Chief Environmental Health Officers Group. So if we can ask them to... No, that not... Oh, this bit, sorry. Okay, so can I refer members to page 15 of the meeting pack? As members will note, 15 written submissions have been received on the bill, and today we are taking oral evidence from the Chief Environmental Health Officers Group. The suggestion is that we also take oral evidence from the Cooperative Food representing food retailers, Pubs of Ulster representing the hospitality industry, and Fermanagh District Council and Ballymoney Borough Council representing councils who have a somewhat different view to the views expressed by the Chief Environmental Health Officers Group. Are members content to invite these organisations to present oral evidence on the bill?
Agreed.
Yeah. Okay. Can I advise members that the Examiner of Statutory Rules has provided a report to the committee on the delegated powers contained within the bill. This is at page 16 of your meeting packs. The Examiner has raised concerns that the powers contained in clause 14 are too wide, ranging to be contained in secondary legislation. These powers would allow the Department to substantially amend the Act based on recommendations produced by the Food Standards Agency when they undertake the review of the legislation. Initial discussions have indicated that the Food Standards Agency accepts these points and is working on producing amendments to the bill. And can I seek agreement to forward a copy of the report to the Food Standards Agency and the Department, and advise them that the committee will wish to discuss these issues further and any proposed amendments when the Food Standards Agency comes before the committee again in February?
Agreed.
Okay, can I refer members to page 22 of the meeting pack, which contains the written submission from the Chief Environmental Health Officers Group, and also refer members to the yellow bill folder, which contains the information relevant to the bill, including a clause-by-clause table. And in doing so, can I welcome Fiona McClements, Larry Dargan and Damien Connolly. You're very welcome. Thank you. Can I refer members... Sorry. Okay. No bother. Okay, thank you very much for coming along today. Can I ask you to go ahead if you have a presentation?
Thank you. My name is Fiona McClements, and I'm the Director of Environmental Services in Dungannon and South Tyrone Borough Council. And my colleagues and I are representing the Chief Environmental Health Officers Group, CEHOG, today. I'd like to thank the committee on behalf of CEHOG for the invitation to provide comment on the proposed Food Hygiene Rating Bill. The committee will be aware that CEHOG has already provided written evidence on the bill. I'm joined today by Larry Dargan, who is the Principal Environmental Health Officer, Food Control, Western Group Environmental Health Committee, and Chair of the Northern Ireland Food Liaison Group. I'm also joined by Damien Connolly, who is the Environmental Health Manager, Food Safety and Port Health with Belfast City Council. Firstly, the Chief Environmental Health Officers Group would support the introduction of the Food Hygiene Bill, requiring businesses to display food hygiene ratings, and recognises that this bill has the potential to better inform consumers while encouraging businesses to comply with the hygiene requirements. However, some councils have expressed concerns about the detail of the bill, and particularly that the scheme may be resource intensive. The review should include an assessment of the effectiveness of the scheme in delivering the stated objectives. The consultation was carried out with the existing 26 councils, and support for the mandatory scheme may need to be reassessed in line with the forthcoming local government reform. Corporate priorities for the 11 councils have not been fully developed yet, and this mandatory scheme commits councils strategically within the food control section at this time of transition. Furthermore, the Food Standard Agency's focus is increasingly on food standards work, food fraud and health improvement, while there is likely to be a reduction in the food safety grant to the councils from the FSA, which will inevitably contribute to the increasing budgetary pressures. Taking account of the flexibility within the Food Law Code of Practice, which help reduce the inspection burden on businesses and the financial stresses that councils are facing, it is likely that many food premises will not be inspected as often as they used to be, or in the case of lower risk premises, they may be removed from inspection programmes altogether. This may not be the expectation of consumers. The proposed food hygiene rating bill appears to be prescriptive in nature in terms of specific response times and processes. CEHOG recognises the need for agreed standards, but is of the opinion that they should not be absolute legal requirements and are more appropriate in statutory guidance rather than in the bill itself. I'll now outline comments in reference to certain clauses highlighted by some CEHOG members. Clause 1, Food Hygiene Rating. Consumers may assume that all premises are subject to a reasonably frequent inspection programme to ensure ratings are periodically updated. The Food Law Code of Practice permits the removal of lower risk premises from inspection programmes, an alternation between inspections and lighter touch interventions for the majority of other premises. Light touch interventions, which may replace inspections, would not collect sufficient information to produce a food hygiene rating. Therefore, for some premises, there is no mechanism to ensure the renewal of their rating, and these will, over time, become outdated. What constitutes an inspection for rating purposes needs to be more clearly defined and consistent with requirements for an intervention rating within the Food Law Code of Practice. Clause 2, Notification and Publication. CEHOG agree that businesses should be notified of the rating in writing within 14 days, as is the case under the voluntary scheme. There may be exceptional circumstances where this may not be possible, and CEHOG would suggest that the time frame be detailed in guidance rather than be prescribed in law. As is the case with the voluntary scheme, councils should be permitted to apply their corporate branding to the stickers in addition to FSA branding. This will reflect the major role that councils have in delivering the scheme and raise awareness that business and consumers should contact the local council if they have any queries. The FSA should cover the total cost of producing the stickers, including the council branding, as part of their contribution to the scheme. Clause 3, Appeal. CEHOG believe an appeal mechanism is an essential element of the food hygiene rating scheme, although some councils have expressed concerns about the potential resource implications. CEHOG supports provision for review of the operation of this appeal mechanism within the bill. Clause 4, Request for re-rating. CEHOG supports the provision that businesses may request additional inspections for the purposes of re-rating. The term inspection for the purposes of re-rating should be clearly defined to be any official control. This is consistent with the brand standard under the voluntary scheme. The shorter time period from inspection to potential re-rating visit may encourage temporary improvements which would defeat the purpose of the scheme. CEHOG supports the requirement for the Food Standard Agency to review the operation of this section, which should evaluate the fluctuations in compliance rates. There is currently no limit on the number of revisits that a business owner can request, and the payment of fees may favour the larger businesses due to their ability to pay for multiple revisits. CHOG are of the opinion that businesses should only be able to demand one re-rating inspection in any 6-month period. This will help reduce demand on councils, whilst allowing business sufficient opportunity for re-rating. A flat fee for Northern Ireland has been suggested in previous consultation responses to be set at a level to help prioritise only reasonable requests. Clause 6. Validity of rating. Concerns have been raised about implication on the potential council resources to monitor the display and the accuracy of stickers on premises. Some councils have concerns that the proposals allow a business to display their old rating until the end of the appeal period. Where a business's compliance has significantly fallen, this will mislead the consumer. CHOG are of the opinion that a business should be required to display the new rating or an awaiting re-rating sticker until the end of the appeal period. Furthermore, councils should be given the power to remove food hygiene rating stickers immediately should there be a significant drop in standards. Clause 7. Duty to display rating. CHOG is of the view that the sticker should be visible to consumers before they enter the premises, so enabling customers to make an informed choice prior to entering. It would be essential that the requirement of these regulations are clear and supported by guidance sufficient to ensure consistency of enforcement. Clause 11. Fixed penalty. CHOG note the fixed penalty amount under the Welsh scheme is set at £200 and consider this an appropriate penalty. CHOG are of the view a similar penalty is required in Northern Ireland to provide a suitable deterrent. An additional offence should be considered to prevent an establishment making any misleading claims or false advertising with respect to a valid rating. Clause 12. Provision of information for new businesses. A key objective of our enforcement and regulatory policy is to support the local economy and in particular to assist businesses in complying with their legal obligations. CHOG is of the opinion that using a legislative instrument to require councils to provide information to all businesses within 14 days of making the registration is not appropriate and should be included in guidance. Councils should have some flexibility in how they achieve the overall objective, providing information in the most appropriate way, and these approaches should be included in the FSA review under Section 14. Clause 14. Review. CHOG supports the District Council should keep the operation of the Act under review. More detailed direction and agreement on the type and extent of review to be carried out by each District Council should be outlined in guidance. Requests for information currently required by the FSA should be revised to reflect the additional requirements so as to avoid any further additional administrative burden. CHOG supports the inclusion of a review by the FSA. The review should measure the progress of the statutory scheme in achieving the stated aims and objectives, in particular improving compliance as determined by ratings, not re-ratings, and reducing foodborne illness in Northern Ireland and providing value for money. The review should estimate the resource burden placed on councils and seek their views on how successful the scheme has been, considering value for money and where they would like to see the scheme improved. The review should include consultation with all relevant stakeholders, especially consumers. Clause 17. Transitional provision. CHOG are of the opinion that historical data should be used to produce ratings for all premises within scope and supports the introduction of transitional provisions to facilitate this. There must be a widely advertised campaign for food businesses covering the whole of Northern Ireland, well in advance of the introduction of mandatory display legislation. There will be additional costs to fulfil these requirements. Clause 20. Commencement. CHOG believe that the timing of the enactment date is very important to councils as they are preparing for local government reform and would welcome time for this reform process to be embedded prior to enactment. In conclusion, CHOG would reiterate its support for the introduction of a mandatory scheme for businesses to display food hygiene ratings. Consideration should be given to making the bill less prescriptive in nature and transferring more detail into forthcoming guidance. There should also be a thorough review of the scheme in order to ensure its effectiveness in making the best use of council resources to improve the health and well-being of the citizens of Northern Ireland. Finally, thank you very much for giving us the opportunity to provide evidence to the committee, and we would welcome any questions the committee may have in relation to the briefing.
Thank you, Fiona. Larry, Damien, is there anything you want to add at this stage, or will we just carry on with questions? Yeah?
No, thank you.
Okay. Okay, and in your written submission, and also from what you've told us here today, you've advised that the Food Law Code of Practice and FSA policy encourages the removal of lower risk premises from inspection programmes or the use of lighter touch interventions rather than a full inspection. But that light touch intervention would not collect sufficient information to produce a rating. Therefore, for some premises, there will be no mechanism to renew their rating, and over time it will become outdated. Does that mean then that businesses who have a 3 or 4 star rating will have no opportunity to renew and therefore then achieve the 5-star rating?
It's not as simple as the rating which they get under the Food Hygiene Rating Scheme. Inspections are dictated by the Food Law Code of Practice, and it uses the scoring mechanism is linked to the Food Hygiene Rating Scheme, but it considers other factors. The lower risk premises, i.e. it rates premises A, B, C and D, and there's an inspection frequency required to check compliance based on the risk rating, A being the highest, E being the lowest. Currently, under the Food Law Code of Practice, Category Ds, which are not handling open high-risk food, are not required to be inspected. They're required to have an intervention, but those interventions are not necessarily collecting sufficient information to give them a rating. And Category E premises are not required to be inspected. In Belfast, I've looked at this, and this would equate to about 25% of the premises which are currently in the voluntary Food Hygiene Rating Scheme.
Give us an example of what category E would be.
For example, it might be, well, at the minute, premises like off licences, which don't handle, any premises which doesn't handle open high-risk food. So say you had a corner shop, it might have a refrigerated cabinet, pre-packed high-risk foods. Unless it handles open high-risk foods, it wouldn't necessarily, if it was a Category D premises, require it to be inspected.
Thank you. If I move on to Clause 2, you'd also, in your written submission and also here today, you'd advised that you're concerned with introducing a mandatory 14-day notification period for councils, given that there could be other emergencies within councils, and believe that requirements should be removed and placed in guidance instead. Would there be a danger if the 14 days was only set out in guidance that some councils could let that slip and be slow to notify businesses of their ratings?
All I would like to say on that is that hasn't, under the voluntary scheme, there is currently 14 days for businesses to be notified in writing, and that doesn't appear to be a problem for councils to achieve that target. It was really to have it in guidance just in case there were exceptional circumstances with that, but it doesn't seem to be an issue at this point in time under the voluntary scheme.
Can I maybe add to the fact, for me, the fact that the FSA have included in the bill the requirement for local authorities to monitor how they're operating the scheme and to report back to committee. There is the option in 3 years' time, if local authorities aren't delivering what is expected in this regard, to seek by regulations to bring it back within the regulatory requirement.
And you said the current timescale at present is 14 days as well.
And for example, in Belfast, our current time frame for issuing letters is 10 days, which is in advance, which is more stricter than the requirement in the Brand Standard.
Okay, and just following that, are you concerned that if there's no time frame specified in the bill in which the FSA must publish a business rating on its website? Are you concerned about that there's no time frame about that? That's fine.
Well, I don't think it's not a concern. It was I noticed, because we looked at some of the concerns raised by industry, and I remember one of the responses in particular made a bit of issue of this. Certainly, from my perspective, I'm not aware of any unnecessary delays by the FSA in publishing information once it's given to them by local authorities. I would expect local authorities also to frequently upload. I know in Belfast we upload every Wednesday, once a week, although the requirement is no more than 28 days. So it's not an issue which either the local authorities or I would expect the FSA should have a problem complying with whatever standards agreed.
I know, and most of us in this room have come from a local council background, and we do know that our local councils are very quick to upload the information, and we'll all be very supportive of them anyway. It was just to clarify that. Another issue is to do with the branding of the sticker. Is there a danger at all that it could confuse customers if we look at council branding on the stickers?
I think that's merely an issue about ownership of the scheme. Councils believe that they are significant partners in the food hygiene scheme as it is at the minute, and I think they simply wanted recognition of that.
Okay.
And could I just add on that too? Like, from the point of view of the administration of this team, it is the council. So if I was a consumer and I was using this scheme and I had an issue with the premises, I think it'd be beneficial to consumers if they could see, because the FSA are not the ones which are going out sorting out enforcing the legislation. I think it's in the consumer's interest to say, that's Belfast City Council. I know I have to ring Belfast City Council to make the complaint to get action done. So I think it's in consumer interests.
Yeah. Tom's just mentioned here, it's a very good point. It is a good point, and it is something that we all recognise in our own council areas, and our constituents would recognise as well. I think we're going to move on. Mickey?
Yeah, thanks for the presentation. Unusually, I don't come from a local council background. I've never been.
Never.
Never. Shame. Well, no, that's good or bad. Anyhow, it's really about the appeals process, because obviously in your submission you're in favour of appeals, but it's really determining sufficient clarity. Who's going to be involved in determining the appeals. Do you think there's sufficient clarity around that for the people who may want to go ahead with an appeal? Type of support or whatever that they may receive?
Well, I personally wouldn't have a problem with the appeals system as it is written. Certainly, it does introduce the element of independence. We currently operate an appeal system. We get very, very few appeals, which I look and reassuring in terms of how we're delivering the scheme and the consistency which we're applying, the fact that we get very, very few ratings. I think the scheme, I think one of the big things in terms of who deals with the appeals is the scheme introduces a degree of independence. Currently in Belfast we could have a senior manager who's checking the scores to make sure they're consistent, and they could potentially also hear the appeals. So within the bill, it looks for a different person to do that, and I think that is a good idea and something that we would have to look at. I don't know if some of the smaller councils that may cause some difficulties with fewer staff, but certainly.
The current situation also has, because of the group system within the environmental health family, there is also the independence of the group food control people. And with the local government reform, then obviously the councils will be larger with more environmental health staff together, working together. So it may not be an issue from an independent or having staff who are separate outside the process having a look at the appeals. It hasn't, again from a personal point of view, it hasn't been an issue in our area to date under the voluntary scheme.
I think with more resources there's a better likelihood of more independence. Obviously with most appeals, whatever area it's in, independence is usually more acceptable.
There is, in general, a very good working relationship even between councils, that if there are issues that those can be ironed out. There is a very good system already existing.
And certainly none of the councils raised any objections to that clause of introducing a higher degree of independence to the appeal process.
Yeah, that's correct.
That's right, thank
Okay,
you.
thank you. Rosie, you wanted to come in on that point, was it?
Yeah, I'm interested in asking about the rating, and if a business is rating an appeal, should they be forced to display the rating that's being appealed rather than the previous one? Would that not place them in a difficult position in terms of their business, where they might lose custom if they have to display a rating which they have an issue about?
I can understand that from the perspective, I suppose, but if we take a consumer perspective, it's important to give a rating that reflects what the officer finds at that time. And I know that there is opportunity, some cases, to fix things very quickly, but I think the idea of the scheme is so that there will be some confidence that when people are not in inspecting, that standards are maintained and improved, and to have a degree of integrity. I think it needs to maintain that.
Can I just add something? In our response, there's a couple of ways of looking at this. If we go out to premises and it had a very good rating, and the rating, there's a significant drop in standards, and if the business is allowed to continue to display that good rating when the conditions are poor, then to me that puts consumers at risk. And the bill, as it's currently written, allows you to do that. On the other hand, if the business is forced to put up the bad rating, then that prejudices the right of appeal and could affect businesses. So what we have suggested in response is that there is a third option, and that is that the business can put up the new rating, and if that's a lower rating and they want to do it and they want to appeal, that another rating can be put up, which is awaiting appeal, or some words to that effect. Currently, under the voluntary scheme, there is a sticker. There is a display sticker which doesn't give a rating; it gives an awaiting inspection. So that's something that's currently used, and that way neither the consumer is prejudiced or the business is prejudiced.
Okay.
Thank you, Chair, and thank you for your presentation. Just on subject of stickers and of the councils displaying their logo, I think that's actually quite a good idea, especially given the move to the new super councils come April. Although I might even suggest actually that no matter what's put on the sticker, they may not recognise what council it is. Especially Kieran's old council.
We'll be all right. We'll get sorted out. This is Orange North Down we're talking about.
Anyway, and just in relation to clause 4, you've noted that there's currently no limit on the number of times a business can request a re-rating, and you believe this should be limited to once every 6 months. Do you think there's a danger that businesses will request multiple re-ratings even if they haven't made the necessary improvements?
Yes, that's a possibility. I suppose we would like to limit it to once every 6 months to preclude that possibility. Yeah.
Is it more than to kind of put the pressure on that the business have to have it as right as they think it is from the start, as opposed to...
That's the absolute value of the scheme. The value of the scheme, in my mind, is that if a premises gets inspected, an unannounced inspection by an officer, and they publish the findings on that unannounced inspection, those inspections are indicative of how that business is proactively managing hygiene. If there's a re-rating requested and there's a reassessment done, the findings then are indicative of the business addressing what they were told to address. And I think the former's the more reliable. But it's about striking the balance between yes, telling the consumers how we are finding the businesses are managing compliance without our intervention, but yet giving them a right to remedy it. And there's two sort of competing agendas, but certainly the fact that the scheme does require what we found in our initial inspection to be displayed for a period of time, that's where the incentive for self-regulation comes, because we have sufficient regulatory powers to deal with non-compliance as we find it. You know, it's the encouragement of self-regulation which the scheme really delivers.
I mean, I suppose, if I may say, that you could view it as if you took the opportunity to have an inspection, find out what your problem areas were, then you fix them, and then you go for another rating, and you continually do that. There's not really much of an incentive to maintain standards, and you don't know exactly when an inspection might be due in some future. So the incentive should be there for self-regulation.
Okay, and just on the back of that, say for instance a new business comes into operation, is there opportunity or is there guidance available to that new business before they would get their maybe very first inspection as to how they can achieve the best rating possible?
That would be, like as we said in our submission, absolutely fundamental to councils is to try to assist businesses in compliance and to support the local economy. And we realise how important it is to support our food businesses. And I would expect every council, I know we look at the applications made to the planning authority for new food premises, we look at the building control applications, and we try to engage businesses before they actually spend money fitting out premises to make sure they get it right from the start. So we would very, very much see it as a major role to sort out their problem, help them, before they start spending money on the premises, give them advice on how to comply right before they even start opening. I noticed too in one of the industry responses they had some concerns about when a new business does open, there's no requirement in the bill for local authorities to inspect those new businesses. And I would advocate that that's adequately dealt with in the Food Law Code of Practice, which requires the councils to inspect new businesses within 28 days of registering.
Okay, thank you.
Okay, Kieran?
Yeah, thanks very much for your presentation. A quick question is, the clause 8, this is I'm referring to, requires a business to verbally inform customers of the rating, and indeed in your submission you have noted that this may be difficult to enforce. Would councils plan to do any test purchases to check businesses are compliant? In other words, would you propose to go out and check unannounced that businesses are compliant with what they're supposed to do?
We would acknowledge that that's perhaps the only way to test that. And we have some experience of using test purchasing in other areas of works, underage sales of tobacco, for example, being one. But that is difficult to do and difficult to plan. And I think it's important that clause is there and that the onus is on the businesses to give information to a consumer should they ask for it. But I guess we haven't ever had to do that yet. And if we found we had a problem, we would develop a process to deal with it.
Or you might possibly ring or telephone to say that you had a concern.
Certainly if we got a complaint, we would probably look at our options of enforcing it. The fact that it's there and that we're dealing with businesses, that we're telling them this is a requirement and you need to address it, is a massive plus for people who are impaired. And certainly the fact that it is an offence there, it gives us the option that if we get a complaint or we think somebody isn't compliant, that we can look at the best strategy to enforce that clause. And that certainly would give consideration to the option of a test purchase type exercise.
But typically our first reaction of councils is because they have, we hope, established very good relationships with businesses, that we would simply talk to them and explain it to them, and it may be an issue of communication or understanding.
Yeah. Well, just take this opportunity as a former councillor for 28 years, unlike colleague across the table, to pay tribute to the work of yourselves.
Thank you.
For keeping us all right, keeping us all safe. So keep up the good work. Thanks,
Thank
Chair.
you.
Thank you. Kieran, George?
Thank you, Chair. And very welcome to your
Thank you
committee.
very much.
Clause 12, in your written submission, you have stated that requiring councils to provide new business with information within 14 days is not appropriate. Can you give the committee any examples of how councils could be prevented from being able to meet this deadline?
And I suppose in response to that, it's not that councils have really the objection, feel it's not appropriate for the 14 days, it's that different councils have different approaches. And as Damien has said, for example, long before a lot of the businesses are operational, long before the 14 days, that information is already with them because certain work has been done through the planning and through building control. So there has a lot, this was really to give councils options of how they would engage and provide this information to council or to the businesses. It wasn't that councils were reluctant to do so. It was they didn't want it as prescribed as within the 14 days of the businesses being registered. What they wanted was the flexibility to do their seminars to the businesses, to write to them long before they opened. It was to give that degree of flexibility. It wasn't that they didn't feel the message getting across was inappropriate, it was just how it was done, because each council in different areas, different types of businesses have found different solutions and different methods of communicating with the businesses. And that was why it wasn't that it was inappropriate. It was just if the 14 days, the council and environmental health tried to work with business, get them as compliant as possible. So it wasn't the issue of the communication, it was just how it was done. to give that degree of flexibility. So hopefully I've answered that for you.
That's grand, thank you very much.
Okay, thank you. George Fergal?
Yes, in terms of clause 14, I just find my notes here. Just bear with me. Yes, you say that that it should measure the progress of the scheme in achieving the aims of improving compliance, reducing foodborne illness, and estimate the resource burdens on councils, etc. Do you think that needs to be specified on the face of the bill?
Yes, we do. But we note that most of the review refers to detail about time limits, and as we've just discussed. But we understand that the rationale for producing a mandatory scheme versus a voluntary scheme, which we have at the minute, is to make improvements in long-term improvements in foodborne illness reduction, and we think that should be measured in any review.
Okay. And in terms of clause 16, you've said that it should contain a definition of inspection for rating and re-rating purposes. Could you explain if there would be possible areas of confusion if such a definition didn't?
Well, again, and this could be accommodated within statutory guidance rather than the bill, but it uses the term inspection in a couple of places in the bill, and it means two completely different things. For example, currently, and I think it's not the intention of for the confusion I would expect to be in the guidelines. We're just making the point. For example, an inspection for the purposes of rating is a specific process as defined in the Code of Practice, which gathers enough information to totally rate the premises. So it's quite a significant level of intervention in the business. Now that's defined in the brand standard as what we would call inspection, a partial inspection, or an audit. If you look at the wording for the purposes of re-rating, it also uses the term inspection. But we know in terms of what an inspection is for re-rating, it's a lesser intervention which verifies that they've carried out the corrective action, but wouldn't collect enough information to re-rate the compliance rating of the premises. It's actually, appreciate it's probably quite technical, but they are two different levels of intervention as defined in the.
But does the test not get done again in terms of?
No. For a re-rating, currently under the voluntary scheme, you have to do a very thorough inspection, looking basically at all of the aspects of the business to collect enough information to check the various elements of the score. Whenever you get a re-rating request in, you basically can go out, check the things that you've asked them to put right in place, so the corrected non-conformances, and look out for any other observations, but you don't have to do a complete inspection. It's a much later touched intervention, which is primarily focused on the remedial action that they have carried out, and that needs to be clarified in the legislation or the statutory guidance, because it uses the same term, inspection.
But it's in the context of a re-rating.
Yes.
So therefore, is that not understood?
No, the term inspection
So your
means two different things, and that's made clear if you look at section 16. It actually refers to the fact that inspection for the purposes of re-rating is not the same as inspection for the purposes of section 1, which is a rating inspection. A rating inspection is different than a re-rating inspection.
Yeah.
Yes.
But given that those are two different things, I think we're getting caught on the word inspection.
Yeah.
Whereas, in fact, if one is against an initial examination and the other is against re-rating,
Yes.
surely it's understood that the secondary one is an inspection because it's an inspection. It just isn't the full inspection because it's against the term re-rate.
Yeah. Our point would be that the guidance should clarify what is meant by an inspection for the purposes of rating and what is meant for an inspection for the purposes of re-rating. To clarify that.
Okay, I get the point, but I'm not sure we get entirely hung up. But I'm not a councillor either. I'm not entirely persuaded that the council name should go on. I think this is about establishing a brand in the public mind around the nature of public safety and identifying that these organisations that are providing food are complying. And I think that's the exercise, not necessarily additional other or vanity information, potentially.
Okay, thank you, Fergal. Paul?
Thank you, Madam Chairman, and thank you for the presentation. I note the point you've made about the 14 days should really be in guidance. Would that be your view in respect of the 21 days that's referenced when it comes to appeals? Should that similarly be in guidance rather than on the face of the bill?
In respect of the number of days for appeal, I think that's more of a procedural deadline, and there was no issues raised regarding that, because currently it is the same as in the voluntary scheme, and that's what councils currently operate. So it would also have a very defined cut-off for the 21 days for appeal, and it would allow then the rating to be displayed.
Because you were of the view that 14 days should be in guidance for the provision of information as well to new owners, and I just made the point, and I have some sympathy as to why we should be putting 14 days or 21 days on primary legislation and not in subordinate legislation, because obviously if we decided it should be 21 days rather than 14, much easier to change a regulation than to amend primary legislation. So it's more a technical point, that if you're consistent around 14 days, then why not 21 days as well, being in regulations rather than in primary legislation?
It would be my personal opinion that as much of the detail that can be left to subordinate regulations and guidelines should be, because, as you said, it's far easier to change than changing an enabling act, and the enabling act should be kept to the bare minimum. That would be my personal opinion.
Well, I would share that. In terms of the appeal, currently it's obviously a different officer who didn't carry out the original inspection. Do you think that goes far enough, that it's a different officer within the same council, or should it be a different council altogether?
And currently, for example, I work for the Western Group of Councils, 5 councils in our area. On the rare occasions there are appeals, one of my colleagues who works centrally for all 5 councils, but not specifically at each council, has helped them with the appeal process. So there is a removal from the actual inspection and that enforcement scenario, and they're able to give an overview. In that situation, I suppose that's quite easy, because that office is also charged with a degree of oversight in terms of monitoring and auditing, so it falls quite easy to that. But councils in Northern Ireland, in relation to environmental health, are very comfortable with inter-authority auditing, and we have lots of peer review processes going on. So it wouldn't be a problem to ask a neighbouring council. Having said that, the new councils are much larger than the existing ones. So I think the danger of getting the connectivity between the officer who carried out the initial rating and someone who might look at that in an appeal is disappearing, or is becoming wider.
Personally, I think that, if a problem with the appeals process materialised through the review, I would be very supportive of an additional stage in the process to make the independence more robust. But an additional process obviously would be an additional administrative burden, and I'd be reluctant to implement it unless it was needed. But I'm totally supportive of it being kept under review and being a fundamental part of the 3-year review of the FSA. And there's a problem, let's put additional controls in place.
Thank you.
Yes, go ahead, George.
Just one small supplementary question. There's a difference of opinion regarding Ballymoney and Fermanagh Council, and I was just wondering what it was. Are you in a position to state what the problems were as far as Ballymoney and Fermanagh were concerned?
We have those.
Can you remind specifically of?
The committee has also received submissions from Ballymoney and Fermanagh councils which take a more critical stance on the bill. Are you aware of a difference in opinion regarding the bill among the councils, and what impact might have this in terms of implementing the bill?
Well, we know that we collected responses from all 26 councils, and through CHOG, the Chief Environmental Health Officers Group, that wasn't invited before we constructed our written response to the committee. So we've attempted to include everything that was said So I'm not aware, to be honest, of exactly the nature of the differences in either Ballymoney or Fermanagh. I could comment if I knew them specifically, but I'm not aware of them.
Was there payment?
Yeah,
I think
I did look at them, and I remember there was a couple of wee differences, but I got the overall impression that most of what they were saying was fairly consistent, with a few wee small areas that maybe they took a different stance on, but I can't recall what they were.
I think one of them was for payment for appeal.
Right.
I think was one. But again, the majority of the responses were similar to what we have said. There was just a few that were only, and one I think was payment for appeal, which puts a new dimension on things, because what you're doing is that the appeal process is that you're actually appealing the officer's decision on site, who was out to visit you. So with any recourse to appeal in most other issues, you don't have to pay for. So if you're not happy and agree with the officer's inspection, then should you pay for that or not? Well, that's obviously Fermanagh has taken a different stance. So that's the only one that I am aware of from memory. But if anybody else is...
I suppose our point in that would be that our main concern would be that, if there are varying differences, especially with these two councils, which we will incidentally be having in anyway, to give us a briefing, and if there are vast differences, there are varying differences, do you think it's going to impact on the implementation of the bill and the time travel of that? Or will we be able to come together on a lot of the issues?
Well, all I can say is that with the work that has been collated for today, the 26 councils were all asked for their opinions, and they have submitted them. And I can only assume that all that were submitted, unless they were later considerations after this was done. But I am not aware of any significantly different viewpoints.
Well, as I say, we'll have them in a committee anyway. They will be invited along to give their witness session here. And just finally, I just want to look at clause 20, the short title and the commencement. And from what I gather, you believe that the timing of the enactment date is important, and I understand the difficulties with us moving into our larger councils and the difficulties surrounding that. Do you have a realistic enactment date in mind of when that could take place?
It's terribly hard to visualise that at the minute, because we're right in the middle of convergence, and with 10 weeks to go, there are lots of uncertainties. I know that in terms of food control, councils have looked very carefully with the cooperation and instigation of our colleagues in the Food Standards Agency at the things that we should concentrate on in the future. And I don't know what that will end up looking like at this stage. So I guess councils will need a degree of time to come together, sort their own policies out, whether they're 2 or 3, and plan whatever strategic direction they want before they manage to go through a mandatory scheme.
Okay. Thank you. Is there anything else from any members? Any other questions at this stage? No? Okay. Can I thank you very much for your time
Very much.
today? Thank you. Members, if you just bear with me one moment, we're going to change things ever so slightly here and go straight to the subordinate legislation first, because we know that our next session is going to be extremely long and some members will have to leave and whatnot, so if we can just get through this first. So if I can turn your attention through then to item number 6 on our agenda, and advise, this is the firefighters pension scheme, and I advise you that the next 6 items all relate to proposals for statutory rules concerning the fire service pension scheme. So I can ask you to go to page 53 of your meeting pack, and can I ask on item number 6, the SL1, are members content that the department makes the statutory rule?
Great.
Yes.
Sorry, Mickey, go
Just to
ahead.
clarify, because it seems to be bringing retained firefighters in with the full-time firefighters, presumably. And the consultation response was from the fire service themselves, they seem in favour of it. Some of the other ones are technical, really, and putting stuff into them. There seems to be a consensus with the fire service that that's something that should happen.
Okay,
Just really to clarify that, I think.
okay, could bring any information on that? That's all we have. Yeah, right, okay, Mickey. Item number 7 is SL1, the Firefighters Pension Scheme Amendment number 3, Order Northern Ireland 2014. Refer members to page 62 of their meeting pack. Can I ask members, are they content that the department makes a statutory rule?
Great.
Okay, members, moving on to item 8, which is SL1, the Firefighters Compensation Scheme Order 2014. Can I refer members to page 101 of their meeting pack? And can I ask members, are they content that the department makes the statutory rule?
Great.
Okay, item number 9, SL1, the Firefighters Pension Scheme Amendment Order 2014, and refer members to page 113 of their meeting pack. Can I ask members, are they content that the department makes a statutory rule? Item 10, SL1, the Firefighters Pension Scheme Amendment number 4, Order Northern Ireland 2014. Can I refer members to page 123 of their meeting pack? Are members content that the department makes the statutory rule?
Great.
And finally, item 11, SL1, the Firefighters Pension Scheme Consequential Provisions, Regulations Northern Ireland 2015. Can I refer members to page 131 of their meeting pack? Are members content that the department makes a statutory rule?
Great.
Okay, members, at this stage I'm going to take a quick comfort break of no more than 5 minutes. We know that our next session we have ahead of us is likely to be quite lengthy, so back in 5 minutes just.
This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland.
Okay, members, we're going to move on to item number 5 on our agenda, which is Regional Task Force on Unscheduled Care. Briefing by the department officials. Can I refer members to page 35 of their meeting pack for the relevant papers and the information sheet produced by the Chartered Society of Physiotherapy on physiotherapies There's physiotherapists in A&E, which has been left on members' tables. And can I advise members also that the department has also provided emergency department activity and performance figures for December, January 2014-15, and these have also been left on members' tables for them to read. Can I welcome Charlotte McCardle, Dr Michael McBride, Jackie Johnson and Michael Bloomfield here today. And can I also just advise members that Dr McBride is here in his capacity as the Chief Medical Officer and not as the Chief Executive of the Belfast Trust. And also, Michael, for your benefit, if you feel that we're straying into anything that is to do with the trust that you feel is not relevant to this, please feel free to say. I will also be making comments if I feel that's the case also. So can I invite you to make your opening presentation, please?
Good afternoon, Chair and committee members. On behalf of my colleagues and myself, I would like to express our thanks and appreciation for the invitation to come and speak with you this afternoon on the work that we are taking forward through the Unscheduled Care Task Group. I would wish to apologise again for the difficulty we had in getting this session arranged, and very much appreciate your offer to accommodate us this afternoon instead of next week. I hope you will have had the opportunity to read and consider the briefing paper which we submitted to you, which sets out in broad terms the strategic approach that we have taken and that we will do a real and meaningful improvement in the experience of care and of patients accessing unscheduled care services. The briefing also built on the Minister's statement of the 19th of November in setting out in some detail many of the innovative pieces of work that we have developed and continue to implement, which will strengthen and improve our urgent and emergency care services. These include, for example, improvements in direct access for patients, helping them to bypass the emergency department, work with Marie Curie to introduce the extension of a 7-day service for out-of-hours rapid response palliative care services, and the work of the trusts working with the ambulance service and other transport providers at local level to improve non-urgent transport for patients. Other examples are that through the Unscheduled Care Task Group, we have set standards for care of older people, particularly transferring out of hospital after 8 p.m. at night, made improvements to the bureaucratic processes involved in many of the discharge plans in order to speed that up, make it easier for the staff, but also to make sure that that's done safely for patients and their families. And also we've planned to train and develop more roles for advanced nurse practitioners so they can support the team in the emergency department. Work is also ongoing to develop a statement on values and principles for urgent and emergency care to guide a strategic piece of work later in the year on how we will deliver urgent and emergency care services in Northern Ireland, and that is in response to one of the RQIA recommendations. But as the Minister's statement also set out, there are some significant challenges which remain, and it is important that we continue to address over these coming weeks and months. I know that in our most recent briefing paper we've given a very high-level overview of performance in October and November. And in terms of the session today, with the committee's permission, and I think you already have the briefing paper, we would like to bring that up to date with a short presentation to the committee on the most recent numbers of patients accessing the emergency departments over January and the holiday period into New Year. This will be particularly important given the recent decisions taken by all trusts, for example, in relation to elective procedures. Michael Bloomfield from the Health and Social Care Board has kindly agreed to do that and has prepared a short presentation which you should have. If not, there are copies here for anyone who doesn't have one. If I perhaps take this opportunity now to hand over to Dr McBride to say a few words before Michael begins the presentation. Michael.
Thanks, Chair. Thank you, Chair. Members, firstly, may I also begin by echoing Charlotte's thanks to the committee for the opportunity to give evidence this afternoon. Obviously, some time has passed since the then Minister Edwin Poots made a statement to the Assembly on the findings of the RQIA review of unscheduled care and announced the establishment of the Unscheduled Care Task Group. I'm also very grateful of the opportunity to come here today and to update the committee in relation to the ongoing work so that we were better prepared for the winter and to strengthen and improve our unscheduled care services regionally and into the future. I also to offer my sincere apologies to the committee that we did not get to update you sooner on this work. I should certainly would wish to assure the committee that we've learned lessons on improving our own mechanisms and processes within the department to ensure that that doesn't happen again. First and foremost, Chair, I'd like to take the opportunity to publicly record our thanks to the very many staff from right across the HSE organisations and professions who have dedicated often their own personal time to the work of the task group, developing the new pathways, developing the new models which Charlotte has referred to, with the ultimate aim of doing better for our patients and clients and those who use our services. Chair, when the task group was established, it was set clear aims for improving waiting times for patients in our hospitals over the course of this winter. But importantly, it was also tasked with ensuring that the people of Northern Ireland, particularly our frail elderly population, receive safe, effective and dignified care. And I don't need to remind members of the committee some of the previous evidence sessions that we had last winter in terms of some of the challenges and some of the impacts that had, particularly on frail elderly people using our health and social care services. I hope that we'll have the opportunity in this session to brief you on the progress that we've already made and will continue to make throughout the remainder of the winter into next year. Members will be aware that the HSC did achieve a 44% reduction in the number of people waiting over 12 hours during the last year. And this progress has continued into 14-15 with the lowest number of people waiting over 12 hours in our emergency departments in the last 5 years, and that's despite a 5.5% increase in ED attendances over 14-15. Michael, obviously subject to your agreement, will give you a short update on this. I would caution, however, that these are unvalidated figures, but it was again an opportunity to provide you an update on the current pressures over the last couple of weeks, and it would have been remiss of us not to seek to provide members with a sense of how the service responded and the pressures in the system and what impact that has had on those using our service. Now, it is important to set all of what we've been doing in terms of the context of a system that, despite the very significant financial and demographic pressures that we have discussed, and I know members are very aware of, a system that does continue to improve. And I hope the figures and information that we'll be able to share with you this afternoon will give you some confidence in that regard. Clearly, Chair, there is a great deal to discuss this afternoon, and again, whether that would be the work that we're doing on values and principles that Charlotte alluded to, the strategy and policy in relation to unshared, scheduled and emergency care, finance, operational service development. We're happy to take questions on any of these issues that you wish, and certainly with your agreement, Chair, I'd happily wish to hand over to Michael to take you through just a brief resume of, like I say, the unvalidated figures at this point in time in terms of how the service has performed over the last number of weeks.
Yes.
Okay, well, good afternoon, and I'd like to thank the committee for this opportunity to join departmental colleagues here this afternoon and to be able to update the committee on the pressures that have been experienced in a number of emergency departments over the last number of weeks and the actions that have been taken to address these. As Charlotte has said, hopefully you do have a short presentation, a number of slides, and I will be brief. The pressures in terms of lengthening waiting times in our emergency departments manifested themselves in particular at the start of last week on Monday the 5th of January, which was the first full normal working day following the holiday period. This followed a 2-week period of significantly higher level of attendances in our emergency departments. There was a 7.5% increase on the same 2-week period last year. That translated into an increase also in admissions from our emergency departments of 3% compared to the same period last year. So quite significant increase in demand from that over that 2-week period immediately preceding the 5th of January. But as well as an increase in the total numbers attending and being admitted into our hospitals from emergency departments, there was also an increase in the acuity of many of these patients. There are a number of indicators which provide a proxy for acuity, but one is the triage category of the patients attending emergency departments. And during this same 2-week period up to the 5th of January, there was a significant increase in the number of Category 2 patients, an increase of 14% compared to the same time last year, and those are patients who are really very ill. There was also a 7% increase in Category 3 patients. In addition to that, there was also a 12% increase in the number of patients admitted with fractures during the month of December, all working together to place considerably increased pressures on our hospitals at this same time of the year. The increase in activity was not experienced in hospitals only. During, again, this same 2-week period up to the 5th of January, there was an 18% increase in GP out-of-hours calls, and within that overall 18% increase, there was a 34% increase in urgent calls to GP out-of-hours. So, as I've said, the result of this increase in activity and acuity was a particularly busy period in our hospitals, and regrettably this meant that a number of patients experienced delays in emergency departments, in particular on Monday the 5th of January and Tuesday the 6th of January, when a substantial number of patients unfortunately waited longer than 12 hours. And you have in the slides the position at 9 a.m. each day from the 1st of January up to and including yesterday. I'm pleased to be able to say that this morning at 9 a.m. there were no patients waiting longer than 12 hours. But as you can see, around the 5th and 6th of January there were large numbers, and delays of this length are unacceptable, and we apologise to those patients who did experience such long waits. What I would say, however, is that trusts prioritise the most urgent patients, and therefore some patients will have had to wait longer while sicker patients were admitted ahead of them, in the context of what I've already said about the increased number of admissions and the increased sickness levels within those. So those are 9 a.m. snapshot figures. They're not the total number of patients who would have waited over 12 hours a day, but typically 9 a.m. is the most difficult time of the day in terms of waiting times. But what those figures do show, I believe, is the steps that trusts took over that period, and that the plans that they already had in place leading up to it meant that the position improved very quickly during the week, from 40 on Monday to 29 on Tuesday, 1 on Wednesday, and no patients over the rest of that week until the start of this week, when regrettably there were 3 patients on Monday and 2 on Tuesday, as you can see. That improvement is consistent with the longer-term trend that Dr McBride has already referred to, and you can see that longer-term trend on the next slide, where you can see in 2011-12 over 10,000 patients waited longer than 12 hours in our emergency departments. That had almost halved in 12-13 to 5,500. Just over 3,000 last year, and to date, to the end of December, there's been a 32% reduction in this year to date compared to the same period, those same 9 months last year. So on track to have fewer than the 3,100 last in 13-14, which again, as Dr McBride said, was the lowest in 5 years. And for example, during the month of December, which was a busy period, that was part of the period in which that significant increase in attendances took place. It was also the period in which there was increase in fracture admissions. In the month of December, there were 92 patients waited longer than 12 hours, whereas the previous year in December there were 163. So the direction of travel in relation to patients waiting over 12 hours is the right one. That said, we're certainly not complacent. We certainly don't celebrate that 3,000 patients are waiting over 12 hours. That is much too many, and the position should be none. But hopefully it reassures the committee that progress is being made in that regard. 12 hours is, of course, only one indicator. There are a wide range of indicators, in fact, particularly quality indicators, but in relation to time, 12 hours is only one, and that improvement is to be welcomed. However, 4 hours is where we really need to be. The vast majority of patients are seen, treated and discharged or admitted to a ward within 4 hours. And it's fair to say that regionally the position is broadly unchanged for the past number of years, and further improvement is required. What I would say, and I fully recognise that 12 and 4 hours are the ministerial standards, what I would say, if you look at the position in relation to 6 hours, a number of our large emergency departments are around the 90% position in relation to 6 hours, which gives some sense that if patients aren't treated within 4 hours, how long the majority of them are waiting. So just perhaps if I could conclude by saying something about how the position in the emergency departments was improved during last week in the face of that increase in activity that I've outlined. Trusts had all reviewed and tested their escalation plans before the start of the winter. That was one of the areas of work taken forward under the Unscheduled Care Task Group, chaired by Chief Medical Officer and Chief Nursing Officer. Those escalation plans have a range of measures to be taken depending on the circumstances at any time, and they include some of the things that we've listed there: opening additional beds, increasing staffing levels, extending services such as social work, pharmacy, occupational therapy, physiotherapy into the evenings and at weekends, having a particular focus on discharge by carrying out additional ward rounds. But one of the measures within those escalation plans that has attracted some attention in the last week is the postponement of non-urgent elective procedures. Taking that decision to postpone non-urgent elective procedures is certainly not taken lightly. The impact that has on those individual patients who have their procedure postponed, many having waited a considerable length of time to have it, and all of the plans that they make. The impact it has on those patients is very much recognised, so it is not taken lightly. It is, however, an appropriate part of Trust's normal escalation plans to ensure that the sickest patients are prioritised by freeing up both bed capacity and medical and nursing staff to care for emergency patients. And last week, from the period 1st to the 9th of January, it was necessary to postpone the procedures of 179 patients. This week, from the 11th up to the position as we understand it at the end of the week, by Friday the 16th, 13 patients will have had their procedures postponed. It is regrettable that this measure was necessary, and again, we would apologise to those patients affected, and I can assure the committee and indeed those patients that trusts are taking steps to ensure that those patients have their procedures rescheduled as quickly as possible. So in conclusion, Chair, I believe that Trust's escalation plans have worked effectively over the last 2 weeks in quickly improving what has been a very challenging position, and our hospitals remain very busy at this point in time. There will, however, be a regional debrief to identify what learning there is from the experience over the last couple of weeks, and no doubt that will identify areas where further improvements can be made. Thank you.
Okay, thank you. Is that presentation, that's us finished with that? Okay. Can I just before I ask a question and bring members in, can I just remind the four of you to use as little jargon as possible, because for some people they will understand it fully and others might be, and I was glad you started to explain when you talked about Category 2 and Category 3, because that was going to be my first question, is can you please explain what that is? So if you could just try with that, that would be good. Can I just ask, first of all, you spoke there in your presentation about the postponement of the non-urgent elective procedures, and do we have any, or have you any time frames or any timeline of how you're going to claw that back? How you're going to manage that?
Yes, the board has sought assurances from all of the trusts in relation to the patients who have had their surgery postponed. The numbers vary quite considerably across the 5 trusts, but all trusts have assured us that they would expect to have those patients to have their procedures within the next 3 to 6 weeks.
So they imagine then within 3 to 6 weeks they will be back on track again to their original timelines? In
relation to those patients who would have otherwise been treated last week or this week, they would expect to treat those patients within the next 3 to 6 weeks.
That's good, and that's good to hear, but is that then going to put us back then with the next tranche of elective surgery? Are we going to get caught up at some stage and be back on exactly where we would be if we hadn't have made this decision?
The board's expectation certainly is that we have contract volumes with each trust in relation to each specialty, whether it's for outpatients, whether it's for day cases, whether it's for inpatients. We have those contract volumes. The events of the last 2 weeks don't change those. We still expect those volumes of activity to be carried out over the year. That's not without challenge, but we would expect it to be, and we will be putting in place arrangements to carry out those procedures. It's a relatively small number. On average, in Northern Ireland, there's about 4,800 procedures carried out each week, on average. That will have been lower. It will have been planned to have been lower in the last week or two because of the expected increase in unscheduled care pressures at this time of year. But I think it does give a sense of scale that if on average there are 4,800 procedures carried out per week, and it's been necessary to cancel about 190 or postpone about 190, catching up for that scale of activity doesn't present a significant challenge.
And just to add to that, Chair, from the department's perspective, certainly again on behalf of the system, we would wish to apologise to those patients who have had their procedures postponed to be rescheduled. If you've already been waiting too long for a procedure, to have that postponed even by another 3 to 6 weeks, and often in the circumstances that we find ourselves over the last number of weeks at very short notice, that was certainly not something any of us would wish. From the department's perspective, the department will have a clear expectation that trusts will deliver, as Michael has indicated, the volume of procedures in line with the agreements that have been established between the respective trusts and the Health and Social Care Board, and indeed the department will be seeking assurances that that is the case. So there will be, as you say, no comfort sought or comfort given in relation to that. The targets that we have in relation to the electives remain. Clearly, we had a system that was dealing with a significant period of unprecedented pressures, and unfortunately these steps needed to be taken in line with the escalation plans which have been developed by the trusts to respond to these sorts of eventualities. But it's deeply regrettable, and again I just for the department to apologise to those patients and indeed their families who have been affected in this way.
Okay, thank you. I'm sure there maybe some members will pick up on this as we go through. Kieran, do you want to go ahead?
Yeah, Chair, thank you very much. Thanks very much for your presentation. And first of all, can I say I welcome that apology from Dr. McBride, because every member around this table would know the disaster that we've been through these last 2 or 3 weeks. And we want to find out, certainly the committee wants to find out, if the task force, the task force is made up of yourselves, and I've got a copy of the members, and the members of that task force is 15 of the most senior health people in Northern Ireland, excluding, I don't think Mr. Bloomfield's not on it, or is Jackie Johnson, so you can relax for a moment or two. But surely, Michael, you as chair and Charlotte as deputy chair must be hugely embarrassed of what has happened, because I mean, I'm in the health committee a number of years, and maybe not yourselves, but come back on a regular basis with the same problem. And I want to know on behalf of the committee, do you, as a task force, know what the main cause? I mean, we've heard what Michael has said about up until now. The main causes of what we have just gone through in the last while. Poor performance in the emergency department. Is it a money problem? Is it a problem with the way the hospitals are internally organised? Is the problem the public's inappropriate use of emergency departments? And we must bear in mind, as I understand it, that Northern Ireland is the worst area within the UK for this to happen, despite the fact that we spend more per head on our patients, our population. Can you tell the committee today, once and for all, that the last health minister set up this in July, I think it was last year, so you had 6 months to prepare for what we've just gone through, and we haven't even had the winter yet. Well, we're having it now in the northwest of Northern Ireland at the moment. It's probably spread to the rest of us. How are you going to cope if the situation gets worse? Perhaps you would
Okay, I'll maybe start off, and I'll maybe then defer to Charlotte to take you through some of the detail of the work and achievements to date of the Unscheduled Care Task Group. But just firstly to say, as the paper which you have before you makes clear, the extant accountability arrangements of this in the system remain. So individual trusts are accountable for their performance across all the spectrum of care that they provide, whether that's elective activity or whether it's urgent and emergency care. And indeed, the performance management of that in terms of actually how well they're doing, they're held to account in processes which the Health and Social Care Board has responsibility for. The Unscheduled Care Task Group is perhaps a fairly unique arrangement where we brought, as you quite rightly say, Kieran, the senior professional and executive leadership in the entire health service around one table to ensure that we are taking forward clinically led, managerially supported and strategically coordinated activity to improve some of the pressures that we see in our health and social care system. Now, again, I think it's fair to say that the pressures that Michael has alluded to in terms of the facts, the numbers, do point to the fact that not only here in Northern Ireland, but right across the United Kingdom and indeed in the Republic of Ireland, we had a period of unprecedented pressure. Your question you rightly ask was, what's the cause of that? At this point in time, it would be speculation on my part to actually seek to understand what actually contributed to that, because as many commentators have said, we weren't particularly into the flu season at this point in time. We didn't particularly have a particularly bad period of severe weather. So what actually contributed to it? At this point in time, I'm not in a position to respond to that, but what we can say, it wasn't a pattern of pressure that was peculiar to Northern Ireland. What I can say is, in terms of, am I embarrassed in terms of how we respond?
Not only you, the entire team.
I think,
made up.
sure.
Yeah.
I think that we had anticipated this would be a period of significant pressure. I think the entire health and social care system in Northern Ireland learnt from the experiences of last year and the failings, let's be clear, the failings of last winter, the fact that we had significant problems last winter, and as a result of the RQI review and the recommendations within that, and the progress that we've taken forward through those recommendations being overseen by the Unscheduled Care Task Group, we are in a very different situation. One of the key recommendations within the RQI review was that Northern Ireland would develop both trust and regional escalation plans to deal with this sort of eventuality. So those plans had been developed by trusts. They had been tested by trusts in the run-up to the winter. Assurances had been sought by the Health and Social Care Board from each and every trust that those plans were in place and had been tested, and that assurance was provided to the department because the department was asking for that assurance. So this sort of situation didn't happen as it did happen elsewhere. So we had planned for this, we had prepared for this, and the plans, we did respond to this, and it did work. They did work, but it did certainly, yes, inconvenience those people waiting elective procedures, non-urgent elective procedures, who we had to postpone. But, let's bear in mind, we did not have signs outside our ED departments, as we had in some parts of England, saying major incident. We didn't have any of our trusts in Northern Ireland declaring major incidents. We had planned stepwise escalation and response across all of the trusts in Northern Ireland to the pressures that we're seeing. I've no doubt that both members and indeed the public may be confused at some of the mixed messages that have been reported in the media. On one hand, we have crisis, and then we have chaos, and then on the other hand, we have what crisis, what chaos. Our hospital and our health and social care system were tested. They were tested because of the significant numbers of patients that we saw, sick patients that we saw, and the system responded well. And all of those staff in health and social care, both in the community and the acute sector, responded very well to those pressures. It was certainly a time, and Charlotte and I have had the opportunity to go out and talk to staff. Staff felt under significant pressure, but the system coped and managed, and it didn't fall over. In terms of the achievements of the Unscheduled Care Task Group, they have been significant. Charlotte, maybe you could just highlight some of those.
Kieran, I'd like to say that in terms of, I don't feel remotely embarrassed by what has happened, actually.
Well, I've had constituents come to me that say that their appointment, I was at a gathering this morning, and it was on a planning appeal, and the lady had to adjourn her planning appeal simply because her surgery was cancelled over and over again, and that reflects right through the community.
And I accept that.
Again, I would apologise most sincerely for any patient, and I did pick up on the media some of the personal stories of people who had been affected, and they're significant, and you know, they've rearranged their lives to have this procedure done, and then at the last minute it's cancelled, and that's very regrettable. But I think that I hope that I'll demonstrate by sharing with you some of the successes of the task group that we can see that if actually we weren't having this success, we could have been in a much worse position. And one of the big success actually has been the escalation group, which Michael chaired. And they were working between, Michael Bloomfield, between September and November really in supporting trusts to look at their escalation plans, beef them up, test them. That all happened before Christmas. We met as an unscheduled care task group just before Christmas. We checked with everybody that their plans were in place, that they tested them, that they were working. And I think the fact that the system has been able to respond as quickly as it has been over the holiday period is testament to the work that went on in that escalation group.
I'm just looking at the escalation plan. And the first one, additional beds opened, right?
Yes.
Surely that must be a contradiction in terms of the Transforming Your Care, where you're proposing to close over 160 beds.
But
and here we are turning the Transforming Your Care up on its head, and your additional beds, which we welcome to sort the problem out.
Well,
Is Transforming Your Care going in the wrong direction?
Well, what we experienced was a surge in demand. Michael has already shared with us the increase in hospital admissions at 2.5% and the increased attendances is 7% at the ED. So in terms of escalation, our response to that has to be a beefed up response where all hands to the pump, open as many beds as we can to make sure that the patients are cared for safely. That is our priority and our concern.
And that will continue?
Absolutely.
So therefore the Transforming Your Care reduction in beds is gone out of the window?
While we're in this escalation phase of increased pressure on our system over this particular period, those beds will be turned down again and back to normal functioning once we get over this surge of activity.
But if I could just come in there and back to Kieran's original question that he had asked, and you've told us about the various things that you have done in the run-up before we had this problem that we had with any departments. So it's gone back to that. There were lots of things put in place, and you know you were on your way for something that was going to be successful. You were going to be able to deliver. Then why did we end up in the position that we were in, which was, I think, Kieran's original question. He had talked about, was it due to money? Was it due to the organisation, the internal organisation? Was it due to people who misuse any, which we know happens as well? And I know, Michael, you had said at this stage it's purely speculative. So if we had all these plans in place, why? Can you give an opinion on that?
Well, I think, as Michael has already said, we don't have the detail of it because we haven't had the opportunity to analyse the information to that level. But what we can say that this was an unprecedented surge over and above what we put in place.
When will we have that information, do you think, or when will you have that? Or
Well, again, I mean, we have, I'll defer to Michael in a second. I mean, we have some of that now. I mean, we know, for instance, we know the raw numbers, and again, they're not validated in terms of the actual numbers of people who are attending our emergency departments. In terms of the Category 2s, those are the people that need to be seen within 10 minutes of arrival. So these are sick people. They don't need to be seen immediately, but they do need to be seen within 10 minutes of arrival. So that was up 14%. Yeah. The number that need to be seen within 7 minutes, the number that need to be seen within 20 minutes, was Category 3, was up 7%. So these were sick patients. And if you actually talk to, as we've had the opportunity to do, talk to the medical and nursing staff on the ground in the emergency departments and those on the medical units, anecdotally, and again it's anecdotally, what they are indicating is that they were seeing increased numbers of frail elderly patients who were sick. And what that then created was, obviously we cannot discharge people before they're medically fit to be discharged, but if you're frail elderly people coming into hospital in increased numbers, which we most certainly did, we had a 2.9% increase in admissions, then it does take a while for those patients to get the appropriate medical and nursing care to actually be ready and fit for discharge. Now, I think we need to look, I don't have the age profile of those patients at this point in time. That's talking to those working on the front line, that's their impression. Why did that happen? Again, I can speculate. The other thing which, talking to the doctors and nurses, is we had a large percentage, they say, of people, which we normally see at this time of year anyway, with exacerbations of respiratory conditions. If we talk, we had large numbers of people with fractures. A 10% increase. Now, again, as others have commented, it wasn't particularly severe weather. We had a period of mild weather. If you remember, we had 2 icy mornings. I don't know whether that sharp change in weather was a factor and whether that contributed to the increase in fractures. For instance, we also had an alert from the Department of Environment, a poor air quality alert during that period in terms of increased air pollution. We know the links between that and exacerbations of people with asthma and chronic respiratory disease, whether that was a factor. I mean, these are all speculative at the moment. But you're absolutely correct, Kieran. What we need to do is understand what happened, because it didn't just happen here, didn't just happen in Northern Ireland, it happened throughout the UK, and it happened in the Republic of Ireland, and there was something unusual in terms of the set of circumstances which contributed to the pressure. I think, however, and I have some confidence in saying that, unlike other parts of the UK and the Republic of Ireland, the health and social care system in Northern Ireland stood up to that period of sustained pressure. We didn't stand up last year. This year, because of the planning, the preparation, the work of the Unscheduled Care Task Group, we were in a much different and better place. The work of trusts, the assurances sought by the board, and the work of the Unscheduled Care Task Group, and some of the other things which we've been taking forward as part and parcel of that work, which I don't know if you want to...
I just want to make a point, though, here as well. We're not here just specifically to talk about what happened.
Sure. No, I appreciate that. Yeah.
We're looking at going right back to, the autumn. And we do know in autumn time there were a lot of 12-hour breaches then as well.
Absolutely.
It's not just this week's period. So I don't want everybody just to get fixated on that week. We need to look at the job that you're doing, the job you've done since it's set up, and tease that out a bit more rather than just concentrating on that one week.
I'm very conscious of that, Chair, and obviously we're conscious that this again was a postponed meeting, and again we apologise for that, and we would have wished and certainly would have preferred to be giving you an earlier update in terms of the work of the Unscheduled Care Task Group. But again, obviously the two are quite wrong for us not to reflect and give you an update on the current situation and indeed the situation over the weeks immediately leading up to
Finally, Chair, I mean, everyone around this table has a huge admiration for the work that has been done in our hospitals and GPs and all
absolutely.
I've asked the question, is it a problem of money? You haven't answered me that, but I am very concerned about the elderly you mentioned there. If we don't look after the elderly, and some of the trusts, my own included, has reduced the domiciliary packages from 3 to 2, I think it is. That means that those people are going to run the risk of breaking a leg and being back in the hospital. Can you get over that?
Well, I mean, obviously, as Chief Medical Officer, it's not for me to advise on financial matters. But let me just, allude to concerns that the then Minister, briefed the committee on when I was last here. And I had raised my concerns with the Minister in terms of the impact of some of the trust contingency plans and indeed the deficit that we face in our budget. And thankfully, due to the decisions made at the Executive, that gap was closed. But we still do have, as the PermSec indicated when he was last presenting here in evidence, a gap of some 80 million. There is no doubt that will have an impact, and there will be some difficult decisions that we will have to make in terms of health and social care, and there will be some decisions which we will have to make short term in terms of where those savings can be made, which strategically we may not have wished to make. But in terms of the
elder people,
but in terms of we have indicated that this is a priority area. We've been very clear, and the Minister's very clear about the priority he affords unscheduled care. The then Minister and the current Minister has been very clear with the priority he affords this. In terms of the additional 80 million that we were grateful from the Executive that we secured in terms of June and October monitoring, 31 million of that went to unscheduled emergency care and flows. 5 million went in relation to winter pressures in planning and preparation for this winter, and obviously we have used that money as well in terms of actually responding. But I think also, let's put it, it's important, Kieran, also to put it in the wider context that over the period of this comprehensive spending review, as the Minister and indeed the PermSec and Julie Thompson previously provided an evidence to you, we have delivered savings as an HSE and department of some 490 million. We have committed to delivering 170 million next year. That'll be some 660 million over the period of the comprehensive spending review, which is in line with what was indicated in McKinsey in terms of efficiency savings that could be made across the department. And yet we've delivered those savings at a time which, as Michael has alluded to earlier, where if now it's only one measure of the health service, but and in many respects a very crude measure, where we have seen year-on-year improvement in terms of, yes, 12 hours, and it's not acceptable anymore, it makes more than 12 hours, but we're seeing improvement there. We're not seeing the sort of improvement that we need to see in 4 hours at this point in time. And actually, we're using fewer hospital beds than we were using in 12-13. So, I think we're making steady progress in terms of actually using the resources, the taxpayers' money that we have, more efficiently and more effectively. But again, that's a matter which is really out with my competence to brief the committee on.
I recognise, and we do recognise, that there have been improvements have been made, but I don't think the question is it's not going to go away. The question as to why our emergency departments, why there is this poor performance, and we're not talking about just that week at the beginning of January, because there was poor performance back in October, November as well.
There certainly was, Chair.
So
Absolutely.
it's not a question that's going to go away, it's a question that's going to be asked. And I think as a committee we would appreciate, even if it is looking at that last week and the findings that you come up with as to why there was that major spike that caused the problem. I think we would be very keen to get that evidence back and that your findings back as soon as possible, because it isn't. We are going to continue to ask it.
But we're very happy, Chair, to provide that information, either in written format or to come and brief you again when we've actually carried out that analysis. We're very happy to do so.
Okay.
That would be helpful to members.
If we could just get back on, as I say, we're here to discuss the task force and what up to date and what has been done, and whether that's successes or whether it's not successes, because it's like everything, there are successes and sometimes there aren't. So we need to be open and we need to be honest. So can I just bring in Fergal at this stage?
Yes, Chair, thanks very much indeed. Given that you put this on the table, feel the need to just interrogate it briefly at the start in terms of the graphs here and things. Obviously, you've agreed 12 hours is the ceiling here, and you've gone from, this drop, because that's the drop in the numbers greater than 12 hours, while this one clearly reflects insufficient movement on the 4 hour time.
Yeah.
So there's a gap between 4 hours and 12 hours.
Absolutely.
If we were to see 11, 10, 9, 8, 7, 6, that would probably tell and give a much more accurate picture. Can we see that?
That information is available. I alluded to the reason 4 and 12 is in this presentation is because those are the ministerial standards and they're recognised throughout the UK. 4 and 12 hours are the two measures. But we do monitor 6 hours, and as I said, a number of, and I mean our large ED sites, not brought up by some of the smaller sites, a number of our large ED sites are at or around 90%, some slightly over 90% within 6 hours, but that information is available up to 10 hours.
It's just that sometimes
absolutely.
If it was all 10 or 11 hours and 59 minutes,
no, absolutely.
We would
Points well made.
a statistical lie without.
No, points well made. Accepted. Fergal, yeah.
Now, also in terms of the increases in ED, you acknowledge that you put extra staff in there to deal with that percentage increase.
Yes.
So it should have, in your plans, that should have dealt with that.
No. What we put in for the escalation plan was what we thought we needed based on the experience of winter and last year.
Including the major incident.
Including all that happened last winter.
So you should have had enough to cover.
But we couldn't have predicted that we were going to have another 7% surge in a very short time frame. That was the issue, was that over a very short time, for some reason, which we don't know the reason.
This was an escalation plan.
Yes. So we escalated.
With provision.
Yes, and we managed it very well. We put in all of the extra resources that we could muster up, if you like, because it's a holiday period. Staff came in from annual leave. We used explored bank and agency. We got locum medical cover in. We had a number of staff who were on sick leave. So everybody, every additional capacity, we turned down some services in order to free up capacity to support the staff of the front line.
Yes, but wasn't that a failure in a public sense?
Not at all.
Because you cancelled at short notice nearly 200 elective care procedures. I mean, given that the system, you were building up capacity to deal with an emergency, and then you had to eat into the ordinary stuff to sort it out.
Well, no, because we couldn't cope with the additional increase over and above the increase that we expected and anticipated and planned for in a very short time frame. And actually, the reason that we downturned elective activity was mainly to give us some bed capacity and staff capacity to manage and maintain safety, because safety is our priority in all of these cases.
But you as a task force didn't foresee that, or did you foresee that as an option in your task force plan? You didn't. You did or you didn't?
Certainly did in terms of the escalation plan. There was one of the work streams within the unscheduled care task group was to look at escalation. What the service cannot do is provide on an ongoing daily basis the level of staffing in place to deal with a possibility of a particular spike.
I didn't see that in there, in your plan.
In the escalation plan, there is a regional escalation plan which was issued to the service in September. All trusts were required to review and revise their local escalation plans consistent with the regional escalation plan.
Was the public generally alerted to this?
Trusts were required to test it, and the board sought assurance and provided that assurance to the department. One, firstly, that the trusts had tested. The board also sought assurances from all trusts that they had sufficient staffing levels in place throughout the holiday period to be able to maintain patient flow. What has happened, what Charlotte is referring to, is the extent of additional activity over that period at 7.5%, compared to, not an average over last winter, compared to those same 2 weeks last winter, was beyond what would have been expected. That's when an escalation plan is required. There are a range of measures. The Trust did not go first to cancel elective. Opening beds, additional beds, and bringing in additional staff is...
I'm conscious that we're dealing with the specific, but I think it is in the context of your organisation and how it went about its plans. So you put in place the need for extra staff to deal with what percentage of an increase, what perceived percentage, given the major incident last year?
Escalation plans have a whole series of measures within it for trusts but it's for trusts at an operational level, depending on the extent of pressures being experienced, to do an escalating series of measures. Had the increase in activity been 10% instead of 7.5%, they would have done more and gone further to be able to respond to that. That's the purpose of the escalation plan, rather than planning and putting in place additional staff at additional cost for something which may not happen. It's to react. The plans are in place to deal with the expected over that period. The escalation plans there are subsequently activated very quickly to respond to what is happening. And as has already been said, and I think the figures do bear it out, there were 2 very difficult, very challenging days at the start of last week. EDs remained busy throughout the rest of that week, but the escalation plans that Trust put in place brought it back into what might be considered more normal.
Okay. And what, now on the other side, what extra staffing did you put into GP out of hours to deal with that spike?
GP, there was additional funding provided to GP out of hours.
Was it able to cope?
There was 800,000. Mike will give you the exact figure. 800,000 pounds was put into in hours. From basically from November through to March. That would be allowed for 3,500 additional GP surgeries. In terms of GP out of hours, there was an additional 600,000 put in place, which allowed for over that same period from November right the way through to March. That was planned for and put in place and will be in place to March, and that will provide for an additional 12,500 hours of out of hours. There was additional nurse capacity put into GP out of hours. There was an additional cover for patient visits out of hours, additional car put in place. So a huge amount of additional resource was put into GP out of hours. There was a further decision taken by the Health and Social Care Board when the pressures in the system over that period, 22nd through to the 5th of January, to put an additional 10% over and above that.
Did it cope?
Well, to support GP out of hours.
Did it cope?
Well, I mean, in terms of if you look at the response times, Kieran, I think that's probably the best way of looking at that. The overall, the number of GP out of hours calls increased by 18%. The number of urgent increased by some 34%. If you look at the response times, I think the response time showed there were some 90%. I think, Michael, if you want to maybe just give the figures.
During that period, with the increase of 18% in out-of-hours activity, 90% of urgent calls received a call back within 20 minutes, which is the standard. 84% of routine calls received a call back in 1 hour, which is the standard. Again, we want to do better than that.
If I could just add, I mean, in terms of contrasting the situation this year with last year, the department is satisfied that the escalation plans worked. Last year we had to bring in the RQA, as you know, to carry out an inspection in Belfast, Trust and do a regional-wide review based on what happened in Belfast. We had no concerns about that this year at all. The situation was well managed, properly managed. Escalation plans were put in place over the autumn. Kicked in.
How many of the ones who didn't get a proper response out of GP out of hours turn up at A&E?
That information wouldn't currently be available.
Do you analyse that information?
We look at the source of referral.
Isn't it possible that because of the under provision for GP out of hours, that's possibly one of the contributors to your increase in A&E?
I wouldn't accept that there was an under provision, as Dr McBride has already said. 600,000 in planning, forward planning, 600,000 additional was put into out of hours, 800,000 in hours. Once the position of the additional activity over those 2-week period was evident, there was arrangement put in place to expand out of hours for further 10%.
It's a big figure, but was it the right figure?
I believe, based on the response times, with an increase in 18%, which again is a level that could not have been anticipated, 18% increase in calls to GP out of hours, within that the 34% increase in urgence, that could not have been anticipated. I think response times of 90% within 20.
Your question, Kieran, is an absolutely the right one. Was the right tolerance built in terms of every eventuality? And I suppose the difficulty is, if we, as Michael has said, that if we plan for the worst case scenario, rather than actually having a responsive system which can gear up, step up, depending on the pressures on it, then essentially what we would have is we spend a lot of money, a lot of people sitting not doing very much, and actually the service not requiring that. So, you know, the question, I suppose, and which I think is where you're getting to, was that additionality put into, you know, both in-hours GP services, out-of-hours GP services sufficient? I think that if you put it in the context of an increase of 18% in demand, and the fact that the response time to the urgence was 90% still, you know, at 20 minutes, I think that you know, that was the case, but nobody could have predicted the level of the demand.
The point I'm getting at is that you took decisions through this task force, which were about the A&E side, etc., and you may have or may not have, depending on how you look at it, achieved some success. But it's dressed up as failure, or at least presented in the public mind as failure, because you had to take extreme measures to cancel public or elected operations. Could more have been done on the GP side? And that's where, and consistent with TYC, could more have been done on the GP side as a strategic focus to ensure that whatever these spikes are, they get ironed out at that end, rather than over in the expensive.
There are two answers to that. The point that you're making in terms of strategically is accepted in terms of, is there more that we need to do in terms of primary care and community services to provide more alternatives to people attending the emergency department? Is there more that we need to do to ensure that primary and community-based services are perceived by the public as responsive as emergency department services are? Is there more that we need to do to raise awareness, despite all the work that we did in November and December in terms of raising public awareness around the self-management week, which launched by the Minister in November, the whole campaign around Choose Well, etc. Is there more that we need to do? Of course there is. The strategic point you're making is a valid one. Is there more that we need to do in terms of investing in primary care services? Yes. Is there work that was ongoing in relation to look at workforce planning in primary care? Yes, there is. But obviously all of this is also factored into this is the resources that are available to do that. But I think that in terms of the investment that the board put in place around the increase in anticipated demand over that period, I think that those decisions in terms of actually how the out-of-hours general GP service responded, I think, you know, if you look at the pressures on GP out-of-hours, GP out-of-hours services soaked up an 18% increase in demand, and we had our emergency departments, you know, soaked up a 7.5% increase in demand. So the service responded well, in my view, in the context. And back to Jackie's point, certainly as a department, you know, certainly we have no concerns in relation to how the system responded to a period of unprecedented and unpredicted a surge in activity.
Yeah, but I think it would be important to see that information in terms of if a patient's making first contact with GP and isn't getting the contact face-to-face, FaceTime with the service, where they go. I think that's very important. Now, you've marked yourself down.
Have I?
In your yes, significantly.
Oh dear.
So
what have I done now?
What would you just in your last?
Argyle, can I just come in there if you're going to move on to a different line of questioning now, are you? Or are you going the same
Consistent with
line?
what we
It's just
discussed.
that Mickey has a supplementary on what. Is that okay?
Just an issue about the 8 of ours. I'm interested to hear about the money that's been spent on that, soaking up the surplus. The difficulty we have in Newry, certainly in my own constituency, is the 8 of ours hasn't been functioning really. I suppose with 2 doctors is either only one or none. And just to give you one example about the response time, the emergency response time, 20 minutes, we had a case this week, a lady who was having a chronic asthma attack and rang out of hours. Now, out of hours is based in Daisy Hill, so you know there's a correlation obviously with the emergency department. She waited 4 hours approximately to get a phone call back. When the doctor phoned her back, he told her if her condition worsened, she should go to the emergency department. She can't drive, her husband can't drive. He said he would ring the Daisy Hill to get some steroids for her. So she got a family member to go to the hospital. They didn't have the particular tablets. So that family member had to drive at 2 o'clock in the morning to Craigavon to get 2 tablets, prednisolone or something like that. So I'm just wondering how that's actually solving their soaking up, because you can only soak it up if you're there, but if you're not there, then there's an issue. So what happened, the money that maybe should have gone to provide GPs in the 8 of hours in Derry?
I don't know the specifics on that, Mickey, at all.
Sure, just giving it as an example, because it's maybe indicative of what's happening in other places.
I will not sit here and say that there's not more that we can do to improve service and responsiveness. Sir, absolutely not. I mean, I think that the only point I was trying to make is that there had been anticipation of pressure, there had been investment, certainly in primary care, in hours and out of hours, to allow for that increase in pressure. And despite the unprecedented level of pressure over and above what was anticipated, the service responded well. I can't comment on the specifics, I don't know the specifics, and I honestly, apologies again, I don't know the specifics in terms of our service.
I understand that, but I'm just making a general point that if all this money was put into out of hours, then obviously in our area something might happen somewhere.
Well, again, the details of the case would suggest that the GP had made a decision that this was not urgent, because if he'd felt that it was urgent, or she had felt it was urgent, they would have certainly dealt with it very differently than.
But with respect, how did he know whether it was urgent or not?
No, I think that's the point. Well, what happens whenever a call goes in? There's a set time for triage. I don't actually have all of those details, and there will be others better placed within the Health and Social Care Board who commission those services to advise on that. And I really don't know the specifics of the response times in that particular area. But again, if that's something that would be helpful, again, we can provide that to you.
Obviously, we've been in touch with the trust, and they will get back to us.
Sure.
Okay. And Mickey, where did she go?
What happened was the nearest out of hours that people in Newry are being referred to is Dungannon. It's a fair distance away.
It is.
The family member had to go to the pharmacy in Craigavon to access this particular drug.
And there will be many cases of that where things did not work as well as they should have been, and indeed, the circumstances you describe, I don't think any of us would sit and say were things which are defensible or should have happened. And for every one of those, and those are rightly things that we need to learn from in terms of how we ensure that sort of scenario doesn't arise again. But for every one of those, there are many, many more that we don't hear about, because there's an excellent service provided by our colleagues in general practice, supported by the nursing colleagues in general practice, supported by all of those who are taking the calls, who had the opportunity to see in action over the holiday period. So we do have an excellent service.
I would accept that in general terms, the out-of-hours service provides a very good service in Newry, but we only hear about the...
Of course, and we need to learn from that.
And we have to hear about that,
of course you do.
Because it has to be addressed.
And that has to be fed back. We need to understand how that happened, and we need to make sure that we're using that to improve the services provided.
Okay, thank you, Mickey. Back to
Just,
Fergal again.
I'll be brief because I want to let colleagues in, of course. As I was saying, you certainly...
I was ahead, was I, for a time?
You were marking yourself down. So how would you rate your performance as a task group?
Well, I think I don't think we've had the opportunity to get on and provide you an update in terms of the achievements of the task group. And I was hoping we would get, as the chair said, an opportunity to do that in terms of the delivered. The performance of the health and social care system remains a matter for trusts and indeed the board in terms of their holding organisations to deliver against departmental targets. So, there is a separation between the two roles, and the briefing paper makes that very clear. The accountability in the system for performance in relation to either elective targets or how trusts are doing in relation to urgent care is the responsibility primarily with trusts, and indeed the Health and Social Care Board holds it to account. As a task group, I think we've made significant progress, Fergal, and again, if time permits, today we would happily take you through that. Out of 10, I think we started this work in July. I think we were in a very different place this winter than last. I would certainly give ourselves, what do you say? 2? I was going to say 6, 7.
I think actually if you look at the number of patients who have been delayed for more than 12 hours and you see the marked decrease year on year, I think that actually is testament to, our first priority as set by the Minister was to tackle the problem of 12-hour delays. And that's where we focused our energy, and that's where we're seeing the improvement. There are lots of work streams, some which will deliver over the next few months, some which require longer lead-in time, some which require the commissioning process at the board to take them on and manage them. So in a way, it's almost too early to make a complete assessment. But on our number one priority, which was the reduction in 12-hour delays, I think we've done pretty well.
But you're, again, Chairman, the vital important point, you're right, you're absolutely right, Fergal, that last winter, public confidence in our emergency departments and confidence in our health and social care service was severely challenged as a result of what had happened and the RQI review and the findings of that. And I think we were all diminished by that report and its findings and some of the experiences of patients. The then Minister expressed his indignation, and rightly, in terms of some of the findings of that review, and certainly it galvanised, I think, the system to make sure that those sets of circumstances didn't occur again. And one of the primary objectives set by the Minister and then reaffirmed by this Minister was the elimination of people waiting more than 12 hours in our emergency departments, because we know that people waiting excessive periods of time, that they come to harm. We know that it's a poor patient experience, and we know it's a very difficult environment for staff, experienced nursing staff in particular, to continue to provide high standards of care in that environment. And as Michael has indicated, despite the sustained pressure in December of this year, compared to last, we delivered a 32% reduction in people waiting over 12 hours this December compared to last, despite the pressures of an increase in 7.5% increase in attendance. Now, there's no arguing with the facts. The facts are the facts, and I hope that our response, irrespective of how it gets played out and reported and commented on, the facts speak for themselves in terms of how the health and social care system responded this winter. And again, just to commend all of those staff in community, the social workers, the primary care teams, the out-of-hour teams, as Fergal has said, those staff in hospital, for responding in the way that they did. And Charlotte and I have met with them, as I've said, but also, to thank all of those patients and their families who understood that, as Michael has said, some people, unfortunately, during this period on that Monday and Tuesday, had to wait longer than we would have liked, because there were sicker patients that we needed to get into hospital beds to stop them coming to harm. And again, both apology and thanks to those individuals whose procedures we've had to postpone to reschedule, for their understanding, because we fully accept that we would have rather not take that step. But in terms of, as Charlotte said, it's about balancing risk, and it is about making sure that we prioritise the treatment of the sickest and keep hospitals safe, and don't get into a situation like we did last year.
Nobody's denying that success must be recognised where it happens. As I say, I'd like to see the fuller picture in terms of the other stuff. And looking ahead as well, I mean, there's mixed success here, and there was failure in that you had to reach for an extra level of escalation, which impacted very negatively on a range of ill people. But what powers will you have in the future to make sure that the trusts comply with the directions set?
Well, that's probably first and foremost a matter. I mean, we as a department, the Minister, will determine the priorities and the standards. those will be set by the department, and indeed the board then will ensure that those standards are implemented in terms of how we commission services, and that organisations are performing against those standards, meeting those standards. Michael, I don't know if you want to expand on that, or Charlotte.
Go ahead, Michael.
There's a range of accountability arrangements in the system. Trusts obviously accountable to their own trust boards, directly accountable to the department for operational performance. They're accountable to the board, and the board seeks assurance from trusts on the actions that they're taking. But we need to be balanced in that assessment. So coming out of the back of a period of 7.5% increase in attendances, is it reasonable to expect a certain level of performance, to understand that there will be some difficulties? We carry out audits, the board carries out audits within trusts to ensure that good practice in relation to the management of patients is happening, and where that's not the case, we seek plans from trusts how to address that. So there are a whole range of assurance mechanisms in place to ensure that trusts are taking the appropriate steps to continue to deliver improvements, whether it's in unscheduled care, elective care, cancer care, or other areas.
There are important other matters. Just
Two things that are foremost in our minds are the experience of people who use our services, and secondly, the safety and quality of the care that's provided. So we, through the Unscheduled Care Task Group, have set up a number of indicators in that regard. Some work was already, to be fair to the trust organisation, they've already developed many of the quality metrics around emergency care. So there are now indicators on safety, particularly with regards to the treatment of sepsis. There are quality indicators about the care and treatment, how quickly you're seen, your triage times, whether you leave without being seen, a number of indicators, and the patient experience indicators, listening to the voice of the patients and their experience. And those measures are being reported back through the accountability processes of the board back to the department.
Because that's hugely important. The point you're making, yes, a measure of number of people waiting more than 12 hours is an important measure, because it shouldn't happen, and we're making progress. And you're absolutely right, we need to make improvements in 4 hours. And yes, measuring turnaround times for ambulance and all the rest of it is very important. But at the end of the day, and over and above all of that, we need to make absolutely certain that when patients present to emergency departments and they're getting the right treatment and care, and outcomes of that care, as Charlotte has said, against those range of measures, are we identifying sepsis when people present to the emergency department quickly? Are we taking the right steps to make sure we're managing that effectively? Is the patient experience at the right level? Is there more that we can do? And we've worked very closely with clinical teams, with the RCN work and standards that they've developed, with the College of Emergency Medicine, and a basket of indicators that they have developed in relation to measuring the quality, not just measuring the process stuff. Process measures are all very, very important. However, in the middle of all of this, there are patients who need urgent and emergency care, and we need to make sure that we're measuring those things that matter, as Charlotte said, and their experience of that.
And I think we've also set important standards, one being the movement of older people. Back to Kieran's point, I wanted to come in to reassure members of the committee about our responsibility and our focus on older people. Because the majority of the people who use our services are becoming more and more in that category. So the standards that we've set are that people shouldn't have more than 2 moves through the hospital system, and they shouldn't be discharged later than 8 p.m. in the evening. That is information and feedback that we've got directly from patients, their advocates, the Older People's Commissioner, etc., who've made those comments. And the other is that we've designed an audit tool to support the nursing staff, in particular in the ED, to make sure that issues that were raised through the RQIA inspection and review around dignity, respect, pain relief, all of those issues are picked up, and that's been monitored, that's been tested at the moment, and will be implemented across the 5 organisations.
Okay, Fergal, anything further? Okay, thank you. I'm going to bunk Pam up the queue because I know she has to leave for a meeting. So
thank you, Chair. Much appreciated, and I will be brief because I do have to go, and I appreciate if you be brief in your answers to me. I was just wanting to ask a bit more about the targets, the 4 and 12 hours targets that are used. Could you tell me how you came up with the policy of having 4 and 12-hour targets, and also give me the strengths and weaknesses of having targets?
Well, I suppose the answer to that is, the department sets the standards, and these, as Michael has alluded to, and maybe I'll defer to Michael for the sort of evidential basis for those. Those were nationally, also nationally agreed targets, and I say nationally across the the rest of the United Kingdom in relation to certainly England and Wales, and Scotland certainly does, but also they have another measure as well. The Republic of Ireland, for instance, uses a 6-hour target from memory. But undoubtedly, the rationale, particularly for the 12 hours, is that there is research evidence which would demonstrate when people wait longer than 12 hours in ED, particularly if they're unwell, that the risk of them coming to harm increases. So for sick patients, really sick patients shouldn't be waiting excessive periods of time in emergency departments. You will have heard the College of Emergency Medicine and indeed those nurses working in emergency departments talking about exit block. And it really, this is, I suppose, at the nub of this discussion. It isn't about capacity, it isn't about bed capacity, it's about flow of patients through the hospital system. It's the flow of patients in. As Fergal was making the point about alternatives to keep people out, i.e. diversion,
TYC.
I'm sure you'll come on to that. And then ensuring the smooth flow of patients once they're in the ED department through to wards, obviously prioritising basis of how many of them are sick. And then ensuring, as Charlotte was saying, the work that we're doing around discharges and coordinating and streamlining the discharge process back out into the community. So it's actually about the flows. So the 12-hour and the 4-hour are specifically there to ensure that, as I suppose a crude measure of flows through the system and how we're performing against other organisations and systems.
The only thing maybe to add to that is, because as Dr McBride has rightly said, the Department, the Minister set the targets, trusts are responsible for delivering them, the Board is responsible for holding trusts to account and supporting them to do it, ensuring they're appropriately resourced to deliver them. The only point to add that I would add is the 4-hour target. It was in place UK-wide when it was introduced, I think, in about 2007-8 for the first time into Northern Ireland. It was a group of ED clinicians who informed and provided advice and recommendation to the Department and the Minister. The target, certainly in England, I think also in Wales at the time, but certainly in England, the target at the time was 98% of patients within 4 hours, and it was a group of ED consultants locally who recommended to the Department and the Minister that the appropriate target for Northern Ireland would be 95%, not because we can't do as well, but because there are 5% of patients who, for clinical reasons, should not and will not go through ED within that time. So they were introduced in Northern Ireland taking account of clinical advice. And as also Charlotte said, well, those are the two that attract most attention. There are a whole suite of other indicators that are routinely monitored and performance discussed with trusts, such as readmission rates into emergency departments, the time taken from arrival to triage, the time taken to be seen by a doctor, the number of patients who leave the department without being seen, and now also arrangements put in place to monitor those additional targets that the task group, or standards that the task group has identified around elderly patients not being discharged late in the evening and so on. So there's a suite of them, but the 4 hours in Northern Ireland was clinically set.
So, Michael, you described it as a crude measure. Are you happy with those targets, or have you given any consideration to altering the targets?
Well, as Charlotte said, maybe you want to just... I think that those are important measures. Those are established measures in the mind of the public. There is absolutely no doubt that people who wait, who are sick, who wait more than 12 hours come to harm. And there needs to be a relentless drive and a continued focus on reducing those numbers yet further. We're making steady and sustained progress. I don't want anyone, and Charlotte and I have made very clear that it's unacceptable that any patient in Northern Ireland is waiting longer than 12 hours in an emergency department. It's not what any of us would want for any of our relatives. Unfortunately, at present, the circumstances are such that sicker patients do take priority. The Minister has been very, very clear in terms of the fact that he regards that as unacceptable, and he set a very clear direction to the health and social care system in Northern Ireland to eliminate all waits over 12 hours. So I think they're important. I think they're an important benchmark of how we're performing. And what it does is, it asks the question, what do we need to do to improve 12 hours? Back to Fergal's point, incrementally, we're not hitting the 4 hours, and we have not seen an improvement in 4-hour performance. Now, that's not to say things aren't happening to people during those 4 hours. They're in there, they've seen the nurse, the triage is happening, the diagnostic tests have been started to be and have been worked up, and a decision to either admit or discharge has been made. So there's active engagement with the nursing team and a range of other professionals. But it is important that we understand why we're not comparing favourably in terms of 4 hours compared to some other parts of the United Kingdom, and what we need to do to improve our performance. And I would argue that a lot of the work that we're doing in the unscheduled care is actually going to drive that.
Yeah. I mean, I think that the targets are important, and the evidence base is there around outcomes for patients, but I think they have to be taken in context of a range of other indicators, because it makes them more meaningful and more real for the people who are actually using the services, as well as the staff, to support them in order for them to make sure the care that they're providing is at the standard that we would all want for our families. And as the work of the Unscheduled Task Group continues, we will develop more standards in relation to specific specialties and how they're managed in the system.
Just maybe to give you an indication of the underpinning indicators. I mean, in addition to the triage times, there's also length of time patients wait in emergency care broken down by 2-hour time bands, patient and ambulance turnaround times, percentage of unplanned reattendance of patients to an emergency care department within 7 days of their original attendance, total length of time patients spend in the department, number of patients who leave before the treatment is completed, and the time from arrival to triage and from triage to treatment. There's a whole range of underpinning indicators as well.
So you're not looking at altering the targets as the
We're going to expand them, because Charlotte rightly said, it's not how long people wait, particularly if they wait too long, is a measure ultimately of quality, and it's a measure of experience of care. But there are a range of other important metrics which, through the Unscheduled Care Task Group, we want to make absolutely certain that the care that's been provided to patients to get the right outcomes is absolutely as it should be, and we want to make sure the experience of that care is excellent as well.
Okay, thank you.
Okay, thank you. Could I just remind members and officials if we could keep to the points of question and make our answers as succinct as possible. George, do you want to come in on something, or are you? Because Rosie's next for questioning.
I'll wait, Chair.
Is that okay?
Yeah.
Rosie, do you want to go on ahead?
And thanks very much for the presentation. And I mean, I do acknowledge the good work that the health service does and the service that they provide. But it's following on from Pamela's point about the 4 and 12-hour waiting times, and the October-November figures show little improvement, and particularly in Belfast, and those are concerns, and you've talked about that, but I just wonder if you can maybe sort of be very specific about what's the reason for that failure to really make significant improvement. Because I'm asking it because really, if you don't identify it, you'll just keep on doing the same thing again.
Well, I think through the work of the Unscheduled Care Task Group, we have set up a number of subgroups, which are all, well, in the main, clinically led, but they certainly have chair and co-chair of senior leaders in health and social care, and they are generating from the ground up the problems that the staff are experiencing, because everybody, no matter what our role is in health and social care at the department, our focus is on the care and treatment of the patient and making that at the best that we can be. So the staff on the ground are now telling us what would help them with some of the issues that they're dealing with. We've taken that alongside the RQIA recommendations, and we've put together a series of work streams. Those work streams will generate some of the solutions that we need to some of the problems that we're experiencing. They're complicated. It's not particularly, I don't think Michael always says, it's not complex, but it is complicated, and every little change that you make or chink to the system has a knock-on effect elsewhere, and we need to be mindful in all of that. But for example, the work we've done with the older people, so I've already referred to the standards work that we've done. The view would be that a number of older people shouldn't have to go through the emergency department full stop. Now, there are people, regardless of age, that will require the treatment in an emergency department, but for many it's around chronic disease management and long-term condition care. And so the Belfast Trust, and you've alluded to some of the issues, as a result of recognising those difficulties and looking for solutions, have set up BCH Direct, which is a service on the Belfast City Hospital side where older people can go directly there for assessment and treatment, and if possible turn around home again, and if they require admission they will be admitted through that route and they don't have to go through the emergency department. That work has been shared through the Unscheduled Care Task Group with the other trusts, and the other trusts are all looking at similar but different models in managing older people in order to ensure that they have a better experience of care. That's just one example.
Can I just come in on that and just ask, to do with that Belfast Trust initiative, how is that referral made, or is it were you referred there by GP?
GP.
Right.
Yeah. And actually, the feedback from staff is that the patients have a much better experience, and they've been monitoring that, and patients are describing a much better experience and quality of care, and are much happy with the care and treatment that they're getting in that model. So we really need to, sell that as a successful pilot prototype and scale that up across other trusts. The Marie Curie initiative about providing more palliative care out of hours, co-located with the GPs in order to support people stay at home, particularly in the last days of life, where we know sometimes when that situation for the individual and the family can be very difficult to manage, it becomes a crisis issue, and often the person ends up in the last few days of life, unfortunately, going into hospital, often through the emergency care route. So these specialist nurses with advanced skills in palliative care will be there out of hours to support the community team, the district nurses and the GP out of hours, to help keep that person at home with appropriate care and treatment. And I think on a quality level, that is a really important initiative that we've set in place, and those extra posts will be in place from the end of this month. They're just two examples of some of the issues that we are dealing with in order to make sure that there are alternatives out of hospital, particularly for the older population and those with long-term conditions, to prevent them having to use our emergency department.
But you asked specifically also about the performance of the Belfast Trust. Michael, do you want to?
Yeah, well, also, if I could, and I really will try to be brief, if I could just add briefly what Charlotte said, because as has already been said, it is complicated. If it wasn't complicated, if it wasn't difficult, I can assure you it would have been done by now. So, as Charlotte has outlined, one of the issues that really needs to be addressed is those alternatives, so to prevent people coming, to provide more suitable, appropriate alternatives for them rather than coming to emergency departments. But there are still more things that can be done for those patients who do come to emergency departments. I think what it's fair to say, generally, the difficulties that are seen where they show themselves in the 4-hour and 12-hour performance, that is generally, it is not issues and difficulties within the emergency department itself. It is within the flow of patients, and the particular difficulties and challenges are around discharge of patients, and it is simply then a blockage within the system. So there are still more things that can be done within our hospitals in more effective and early planning for discharge, and work is ongoing in that regard. But a significant issue is the extent of 7-day services. Yeah. So people get sick 7 days a week, they get better 7 days a week, and there is a challenge to respond to those who get better on 2 days a week more than the other 5 days. So one of the outworkings of the Unscheduled Care Task Group has been a patient flow paper with a series of recommendations, and the Health and Social Care Board is now working with trusts in order to take forward the specific recommendations from that around putting in place radiology services 7 days a week where they're not currently the case, supporting twice daily consultant decision making. If we don't have consultants seeing patients twice daily, there's too much time spent between to keep things moving. Looking at embedding allied health professionals, so physio, OT, also social work and pharmacy, across 7 days, more than is currently the case. It's there to some extent 7 days, but not 9 to 5, 7 to 7. So there's a range of things to enhance the real 7-day working that need to be put in place, as well as improving the whole planning for discharge. Every patient from when they are admitted to hospital should have a plan for discharge within 24 hours and actively working towards that. So there's still more things that can be done to improve that, as well as investing in 7-day services. In relation, very briefly, in relation to Belfast, Belfast Trust saw a very significant reduction in 12-hour breaches. On that chart that was in the presentation, from the 10,000 year down to the 5,000 year, Belfast Trust accounted for a significant proportion of those at that time. It has experienced difficulties since then, it's fair to say, and in this year to date, they have by quite some way the largest number of 12-hour patients waiting over 12 hours in the year to date. They do, however, have very significant plans in place through a programme called Impact that's within the Trust, and I believe there are improvements being seen from that. The board works very closely with the Trust, both in relation to supporting to improve, but also through the performance management and the accountability arrangements, given what performance has been like over the last number of months. But there are certainly improvements, and my understanding is that, and I don't like using the word only when it's in relation to patients waiting 12-hour breaches, because for that one patient it didn't matter how many others there were, but my understanding is there's only been one patient waited longer than 12 hours in the Belfast Trust in the last week. That is a very different place than this time last year.
Can I just add to that to say that part of the Belfast workstream was implementing the recommendations from the RQIA report, and there was a follow-up inspection in December, and while we don't have the report yet, we understand that RQIA are content that a significant improvement has happened across the areas that they initially found back in January and in their review.
Do you have any detail of those findings?
Of the updated report, we're waiting the RQIA report, which we should have in the next week or two shortly.
Can I just ask one other question? And I suppose it's in general terms, whether it's to do with the emergency department issue that happened last week, or whether it's about waiting times in general. How would you respond to claims that you're not listening to everybody's voice, everybody that has a view who might be relevant to this discussion? I'm referring maybe to groups that weren't included in the subgroups, coming out of the task force, and also comments of Trish McKeown that, we have got ideas, and the suggestion was nobody's listening. So are you confident that you're listening to everybody, thinking outside the box maybe?
Well, I'm confident that we have been very mindful of that, and it's not just about the people who are in the groups. We have set up an expert group across the other three UK countries and ourselves, informing Michael and I as co-chairs in relation to our ideas and proposals that are coming through from the workforce. Some of those have been tested elsewhere. I think it's reassuring to note that much of the work that we're doing is similar to the work that's been done in England at the moment, and in fact,
can I just say, but just to say that you're doing what England is doing isn't a vote of confidence, because there are worse examples of
absolutely
things that are similar to happen in emergency departments. So I don't think it's a good claim to say.
I apologise if I have misworded that. Well, what I wanted to say was that we have a deliberate engagement strategy to deal with, and we have met through the Unscheduled Care Task Group a range of interested parties. The Patient Client Council is also represented by their Chief Executive on the task group, which is the voice of patients. We have engagement with a range of stakeholders, professional bodies, and we're very happy to speak to anyone who wants to give us information or ideas in the future about how we might, if we have overlooked that, but we do have an engagement strategy in place. It's as broad as we thought we could make it at the time. We're happy to reflect on that. The Minister has asked us to take forward a piece of work around values and principles. We are working that up at the minute, and that will be going out for consultation later on, probably in the next month or so.
Just very briefly to add to that, Chair, if I may, just to add to Charlotte's comment, we did have a very active programme of engagement, certainly with professional bodies and organisations. As you're aware, we had 2 events in April and June of last year with the College of Emergency Medicine. We had an event with the Royal College of Nurses and the Emergency Nurse Practitioners Forum to inform this work. We also had a workshop where we had a range of parties present, including the unions were present at that event, and give a presentation at that event in terms of their ideas and their solutions. I would say, however, that in terms of the pace that we've been progressing this work in the real need to have some of this in place for this winter, I think we certainly would have benefited from more time in terms of that preparation and more involvement from a range of other key stakeholders who, I agree with you, have a very valuable contribution to make. But again, we've only but started on this work. I say we only started it in July. We have a communication strategy. We have a very active ongoing programme of engagement, and we will follow up on that. We take that point on board.
So if any of those groups that maybe were making those comments were to come speak to you, they will feel happy then that you're going to be taking their views on board?
Absolutely. I mean, we have been out in all of the 5 organisations speaking with the frontline staff now on a number of occasions, both in the early days of the Unscheduled Care Task Group and more recently over the holiday period. But I have also met with each of the senior nurses in each of the 5 trust emergency departments, and we've had a number of engagements with the RCN through the ED Nurses Forum on particular nursing issues which they have raised with, and I now have in train a plan around the issues that they've raised around advanced nurse practitioners, around career development for nurses, around workforce planning for EDs, about all sorts of issues that they have raised, and effectively they have pretty much open door access to me as the Chief Nursing Officer to listen to their concerns.
Because those working in the front line have the answers, you know.
Okay, thank you, Rosie. I guess this to do with this subject before I bring Joanne in.
You mentioned the Minister. Kieran was welcoming the Minister back into the public domain yesterday, because unusually for him he's been quiet over this past period. I just want to make that point. But just in the groups, I mean, I've met GPs and GP representatives fairly recently, and in terms of in the context of the task force, they would feel fairly excluded, because they are in the front line. I mean, we talk about preventative, people not having to go to emergency departments or indeed out of hours. GPs are the people who normally would deal. And I know, for instance, in Daisy Hill there was a policy with GPs of direct admission, you know, without having to go through the necessarily ED department. But it just seems that they have been, I wouldn't say necessarily ignored, but certainly they feel excluded. Now, whether you feel that it's the same, and we've been meetings with the unions, they would have a similar.
I mean, I accept the perception. I think that the 3 things you do in any major change programme is communicate, communicate, communicate. You know, given the speed and pace that we've been trying to progress this, I think that there are areas that we've certainly improved in that communication. I have personally met with the Royal College of General Practice. I've personally met with the chair of the General Practice Committee, the BMA. We've had some engagement. They certainly have expressed those views to me as well, that they haven't felt that they've been involved as much as they would like to be. I'm very happy that we would certainly continue in that engagement on an ongoing basis. We certainly do have individual general practitioners who are involved in many of the work streams, and certainly very happy to continue to improve that level of engagement. It has been just the pressure of the time to actually make sure that we're making progress. It's been certainly not a deliberate attempt by ourselves as a department through the work of the Unscheduled Group to exclude anyone from this. If people have contributions to make solutions, ideas, we're very grateful to hear those ideas and see how we can take those forward.
I suppose the point is there's no GPs included in the task force. I mean, if you look at the composition of the task force, you might look on it as on a bureaucratic level. I'm not saying it's only a perception, because, you know, GPs, frontline, primary care, deal with on a daily basis. It just seems that they should have a much bigger input.
Well, we have Sloan Harper, who's responsible for primary care services in the Health and Social Care Board, has been working very closely with us on this. As you know, he's responsible for the commissioning of those services. As I say, we have a number of GPs who've been involved in many of the work streams and inputting into that, because, you know, it's a system of care. It's not a disconnected and disjointed system of care, and we're never going to get this right by concentrating on the acute sector and what happens in hospitals, because it's about the front end, what happens in the primary care and community care, what happens in the hospital system, and then actually what happens out in the community again, and it's about the flow through that system. So, look, have we had the time to have the level of engagement, communication that we would have liked? No, we haven't. And can we improve on that? I think we can, and I certainly take those comments on board. Our doors are open. We're happy to have ideas and solutions from anyone.
Okay, thank you. Joanne?
Thanks, Chair. I've been listening very carefully to all the questions and the discussions, and I've noted, Michael, how many times you talk about the system and the system being tested. Let's not forget about the human aspect not just the system. I was glad to hear Sharon refer to the patient more. Patients have been grossly inconvenienced and many have been put at risk. And we all know, some of us have shared the very personal stories of people that have been affected. And your answer is effectively, it could have been worse. So I think for many caught up, whether it be not having their surgery or A&E, I think this staggering, as an understatement of response, is quite incredulous to hear it. Could I start by asking you about the Children's Hospital A&E? And you'll be aware I wrote to you recently, Michael, about this. And from my point of view, I know exactly what it's like to sit and wait in that queue when you have an ill child, and the worry and the fear is exasperated. And when you have a young child who's in pain and can't tell you their feelings, I think it's every parent's worst nightmare. I would like to commend the staff, because the staff are just outstanding, and many of them are exasperated and at breaking point as well. So episodes like we saw recently only puts them under more pressure and the lives of those children under pressure. No child should be expected to wait these lengths of times, and no parent should be expected to endure that, well, as I said, watching their child in pain. So perhaps, Michael, could you update us on what action you have taken since?
In relation to what specifics?
Well, the extended waiting times I wrote to you about.
Well, again, Chair, if I may just add that I think, Joanne, you wrote to me in my capacity as Chief Executive of the Belfast Trust, which is really not the purpose of today's
Not like the answer.
Meeting. And again, I think I responded to your email within an hour. And I've indicated that I would be responding to you in writing form in due course.
Well,
I really don't want to get into
but I suppose we could ask, though, it is a good point to be a comment generally about the A&E at the Children's Hospital, rather than specific.
I think the thing we tend to forget in the middle of all of this, that apart from adult emergency departments, there are regional, Children's Hospital in Northern Ireland and the emergency department there, which is consistently high performing, and Michael will have the details in terms of, it is unheard of for someone to be waiting, 12 hours in the emergency department. It just doesn't happen. And if you look at the 4-hour performance,
it's in the mid to high 90s. I don't unfortunately have the figure.
But I think in terms of the general comment, it would also be important to put it in the context of a particular period of pressure that all children's services experience also in this period. Those of you who will have perhaps been following the media over the period will have seen that there was severe pressure on paediatric intensive care, for instance, over the holiday period, over the run-up to Christmas and New Year. And again, whilst we're not sure exactly what that might be due to, we do know that at this time of year there is an increase in circulating flus and viruses. And one of the particular problems that we see at this time of year, and we are beginning to see an increase in that in the recent Public Health Agency report of the 8th of December, is respiratory syncytial virus, which can cause quite a nasty and severe respiratory illness in children. So I think we've had, at this time of year, unfortunately, just like every other year, a range of conditions and infectious conditions which certainly put significant pressure on children's hospitals, and has been the case right across the UK, and particularly specialist facilities within that. But I think in terms of the performance of the Children's Hospital in Northern Ireland, I think that performance is high. I certainly, back to your earlier comment.
And I would be the first to commend the work of the Children's Hospital. I've used it with my own son. But with regards to, and I thank the Chair for making the answer to this question, with regard to the task group, so are you gathering the views of the parents, patients and the staff in the Children's A&E? Is that contained, will that be part and parcel of?
It's not. At this point in time, as I say, we are thankfully in a very different place.
Well, do you intend to? Has there been periodically those views?
As you'll see for the paper in front of you, the task that was set us by the Minister was specifically in ensuring a system-wide response to the 17 recommendations coming out of the RQI review, the 7 that were specifically for the Belfast Trust, the 10 that were actually regional recommendations and the task that the Minister set Charlotte and I, as CNO and Chief Medical Officer, to ensure the system responded to those and the work stream that Charlotte alluded to that have flowed out of that. So there are no plans at this point in time to include the Children's Hospital or the ED service there, because it is a service which has been under significant pressure, as other services have been right across the UK at this time. Very committed, dedicated staff working extremely hard, as you've said, but it is not an area where at this time either the board or indeed the department has any lack of confidence in the responsiveness of that service. But indeed, I would just want to acknowledge that we are aware that that service and those doctors and nurses and other healthcare workers working within that service have been under a significant amount of pressure at this time.
Well, to me that seems, and again I've heard you use the system word again, that's very, very worrying that that's not been looked at and lessons aren't been drawn from the past, particularly if the children's isn't contained.
What specific problem would you like to flag up that you feel we should be considering looking at?
Well, extended times I've had patients been in touch and, as you know, waiting longer in A&E with an ill child. Surely that's mistakes. We've heard how things keep happening year on year. Surely if that's not flagged up or that's not addressed, this will continue to happen.
I think it's again, I defer to Michael in terms of the performance, but there will be periods where, as in at the adult service, that sicker children will take priority. And unfortunately, we do know, and we know that right across the UK, we've had some very sick children. It's a young child,
as I said at the start.
No, and I accept that. And please don't infer from many comments I made around what we need to do as a system in terms of improving things. That I'm in any way, shape, or form trying to depersonalise this, because again, I know first-hand experience in terms of talking to patients who've been in emergency departments waiting longer than we would have liked, in terms of talking to staff. So there's no sort of sense of myself as Chief Medical Officer seeking to take the people out of this and the personal experience. I've already apologised for those delays. And
flexibility within the task force. If you're rigidly to the 17 recommendations, there's no flexibility, there's no reaction to other measures, it's rigidly to what...
Well, Joanne, if the Minister feels that there was a particular issue around improvement in relation to the performance or the experience of patients or the experience of parents in relation to the services provided in any ED department, whether it's in children's or elsewhere, then that's something which we would take forward. But just in terms of performance...
Well, perhaps just to maybe try to reassure you, one of the functions that the department established and required the board to do is the performance monitoring, management, appropriate escalation and support, etc., across a range of areas. The Children's Hospital, as all of the emergency departments, whether they're type 1s, 2s or 3s, which is the different levels of them, they all come within the monitoring of performance, and if there are any issues of concerns, those are dealt with. I have to be honest and say that the efforts are focused, in relation to unscheduled care, the efforts are focused largely around the 6 sites that have the most significant challenges.
Is listening to the parents not part of monitoring that performance?
That's in relation to some of the other ways of getting feedback that Charlotte mentioned earlier, patient voices. And,
The Public Health Agency lead on a project called 10,000 Voices. They've already gathered over 5,000 stories. They have programmes of work, so they've looked specifically at ED, they've looked at mental health. There is a rolling programme. I'm not sure exactly where
very well aware
children's sit in their work programme, but all trusts undertake patient experience surveys and feedback from the policy of the department around the 5 standards of care, and Belfast Trust will have undertaken that on behalf of the Children's Hospital. I'm not sure what that says at this moment in time. I don't have the detail of it here, Joanne, but I'm certainly happy to follow that up.
I'm just concerned that you have such high hopes coming out from the scheduled care task group, but yet it's so focused, it's so generic. It's surely things need to be, particularly with health, reactionary, because Kieran started the ball rolling earlier this afternoon about previous winters and drawn lessons from other winters as well. You have to be reactionary surely as well, rather than so generic. Can I move on then, Chair?
Can I just ask on that, have we had problems, have they been highlighted in our children's ED departments? Has there been major problems highlighted in there?
No.
No, so it wouldn't be part of the task force.
Can I maybe
But
just...
I did bring to Michael's attention, and you did give me a hold and email very quickly within 20 minutes.
But again, that's another capacity, and there was some, I think, two
that's
specific experiences.
But
So
generally, on the whole, has there been?
Can I maybe just add,
I mean, and I know because I've had children as well that I've taken to any, and they are seen, you know, straight away. Even when I walk into an adult any, it's straight away.
From a performance point of view, there are, and again, we've talked at length, so I'll not repeat it, that there's many measures more than 4 and 12 hours, but in terms of timeliness, it's 4 and 12 hours. There are no 12-hour issues that I'm aware of at all at the Sick Children's Hospital. 4-hour performance is consistently strong, as it is at a number of the smaller sites, which is why the majority of the focus and the efforts in relation to identifying ways to improve performance are targeted at those areas where the most significant challenges are. The Sick Children's Hospital would not be seen to be in that position.
I only hope it doesn't become an issue. It's isolated instances.
Maybe if I could just add, in terms of the children's services, there's a number of initiatives that have been going on over the last couple of years. So in the middle of last year, the department completed a major review of community and hospital-based paediatric services and palliative and end-of-life services, and it involved fairly intensive consultation with parents and indeed children's groups in terms of the improvements they'd like to see both in scheduled and unscheduled care in children's health service. So those reviews have been completed. The policies are now ready to go to the Minister to consider to approve. We expect to have those published quite shortly, and again they'll be setting a whole range of new standards, improved standards of service right across the whole raft of children's services. So we've been active in that on that side of things.
And I do hope no one else contacts me that this isn't going to continue with incidents with the children. You're all fairly confident that, you know, it will not happen, so I hope you're correct in that assessment of it.
And also on the values and principles, again, subject to the Minister approving those as well, there'll be a full public consultation and engagement. They'll cover things like, for example, information and choice. What information and choice and services do patients want? What kind of access? What kind of partnership with the health service? What the compassion and respect the public will expect from the health service. Openness and transparency. So there's a whole consultation exercise that takes place, which has come out of the unscheduled care task group, because we're really only 6 months into the work.
I would be concerned, and Mickey highlighted earlier about GPs not being involved, and I would be concerned it's so rigid, so generic that it's closed, and Rosie highlighted as well, there's so many who aren't included, and yet it can't be reactionary or move or change. It's very rigid, very set in stone, and it's going to tell you exactly what you want to hear with the outcome. That would be my concern. Just finally then, you talk about work of the task force, and I noticed in your briefing you talk about the Trust having implementation plans to eliminate available breaches. Can you highlight more of what's in the task force group to do that? Because I believe it's very, very important to learn lessons from previous years. This isn't the first winter we've had, so how is that going to be fed in, and how is that going to be acted on within the task group?
I think Michael said earlier, we've had a number of engagements with not just the frontline staff, but the trusts, the professional bodies, people who wanted to tell a story to us, those who had ideas about how we'd make those changes, and as a result of that, we have learned from that experience, also the recommendations of the RQIA review, which is a primary driver actually in terms of how we've set up the unscheduled care group. We've taken the learning from that, we've taken their recommendations, and we've fed that in along with the College of Emergency Medicine to feed how we've structured the task group and the work that we have prioritised.
So we've had the breaches last week. The Chair spoke about October, November. The task force is up from July. When will these be eliminated, these breaches, and when do you see the work of the task force coming into play, and will not be sitting here next year talking about?
I don't think that I can give you a definite date of when that will be. I think we're making very good progress. The presentation from earlier demonstrates that. We have more work to do. Some of it is longer term work. It does require changes at specialty level, at hospital level. Those things will take time.
Do you have the confidence that with the work of the task force we'll not be sitting here next year talking about breaches and
Well,
eliminating them.
can I just say at this point in time, we shouldn't be using the term 12-hour breaches. Back to your earlier point, these are people waiting in ED for longer than we would wish. That's the point you made earlier, and that's the point I would now
I'm
make.
very, very aware about.
We don't use the term, and we don't use the term through the unscheduled care task group of breaches. We talk about patients waiting
And
longer
systems.
than 12 hours, and we need to be consistent in that, because back to your point, it's not about depersonalising this. This is people.
So I'm just
waiting longer
referring
than
to the
should.
work of the task
So,
force. If you have
I think
such
we're making
confidence
sustained
in it.
progress on this. I think the numbers and the facts back that up. And we are absolutely committed and determined. The Minister has been very clear in terms of what his expectations are, his requirements of us, and we'll be working to deliver that.
Okay. Thanks,
Okay,
Chair.
thank you, Joanne. Michael?
Okay, thanks, Chair. It's been a long session, so I'll try to be as brief as I can. I can understand how you can get to evidence overload and weariness. Can I say, first of all, that when I went into the department in April 2007, that was roughly when the 4-hour targets came in.
Yeah.
And I understood then that the 4-hour targets were the key target, the critical target. Yes, there was a 12-hour target, a long stop, but the absolutely important, crucial one was the 4-hour, and that was 95% in 4 hours. And that's the one actually I look at. And yes, you've made good progress on the 12 hours, and I congratulate you on that. That's good work. The 4 hours, however, would still seem to be there's a long way to go there. Can I also say, Michael, as far as your graph's concerned, you're showing here over 12 hours, and you're giving us the numbers, but you jump then to the 4-hour weights, and you're in the percentages, and we can't see like for like. So if you are on 13, 14, hitting 78% in 4 hours, it means you're hitting 22% over the 4 hours. So it's just to give me an indicator how many patients are we talking about there. April to December, you're 79%. How many patients are we talking about there who are missing their 4 hours? So I think it's important, because my focus is and always has been the 4 hours. And just briefly, the point that Joanne was making, the Children's Hospital, I've been up with my grandchildren there, and I think couldn't speak more highly of the staff in there, both the clinicians and the nurses, first class. Your 4-hour weights there are almost on target at 93.5 in November, and that's very good, but there's 184 children waiting more than 4 hours, so I think that's, and you've got very good staff, so you need more bodies, you need more people. And it seems to me that when you look at your 4-hour weights and where the issues are, and the issues going back 2012, 2013, 2014, you'll know all this. The 4-hour breaches primarily are hitting in, or mainly hitting in, the Royal, the Mater, and Antrim. And those are 3 areas. And it seems to me that when you look at Craigavon, a major acute, it's hitting 86%. Very good. Daisy Hill, a minor acute, 88%. The Royals at 68, Mater at 69, smaller hospital, and the Antrim at 67. And it seems to me, you would know better than me, but that's where you've got to concentrate on, and that's where you've got to get the investment, and you need more people. Now, Antrim, you've got a brand new A&E in there, and it's about populating it properly. It seems to me, if you're hitting that sort of number, it's not the facility, it's the number of people going through, and that's the story we're always getting, and all of us are getting the same story, where people are sitting waiting, and we know that the 4-hour wait, it's a very good reason. I think prominent doctors in the department explained to me at the time why 4-hour was key, you know. So,
I think I remember those conversations.
yes. So it seems to me that's where you need to concentrate. You need more investment. The Royal sitting at 2,500, missing the 4 hours, and the Ulster trembling on the brink at around 75, and Galvin at 75. I agree with you. You have a very good health service here. It has been working and delivering superbly over a long number of years, but it's not getting the support from all of us in here, voting at the resources that it needs to provide the supply. And I keep talking about supply and demand. If demand's there, supply has to match. Demand goes up, supply has to go up. And it seems to me that the supply is not reaching demand. How are you going to square that circle. You have a task force. Cleverer working will help. It will take you some way, but we've been doing this for years. There's no way out of the fact that you will need extra doctors, you will need extra nurses, you will need extra ambulance crews and so on. You need extra people. So have you any sense of where you need to be in terms of that to give us, frankly, where we should be voting, because we're into very, very serious financial situation. There are certain things that government has to do, absolutely key. Uphold the rule of law, protect life and property, has to be done, number one. Health and social care, there's the second one. And that we have a duty, all of us, but we can only fulfil that duty if you tell us what you need. And you have to invest, you have to be efficient, you have to engage the population. Those are the things that we always talked about. But where are we in terms of what we need to do? We hear what you need to do, and we'll tell you what you have to do and where we're not happy and all the rest of it. But I think you also have a duty to tell us where you think we need to be and where you think what you think we need to do. Can I also say, as far as the board is concerned, because I set up the board, and the board, one of the key things the board is doing, it's been exemplary of efficiency and so on, and to give support to the trusts. And can you take this back to Valerie and co and to Ian? There's been precious little support coming publicly from the board as far as the trusts are concerned. And it seems to me that Belfast is the big fish in the small pond, attracts most of the criticism, and it needs more public support. And I know you're wheeling out John Compton occasionally now, and that's
I think he wheels
that's
himself
good.
out, actually. I don't think.
Well, he's grown a beard, so we don't always
him.
recognise him, you know. But it just seems to me that the board needs to be doing more in terms of supporting the trust, and if they need more money, if they need more support, you've got to find it for them.
Well,
You can start, Chairman.
Well, the board is and continues to work closely with the trusts, and the board has been providing considerable media statements and interviews in relation to this particular issue.
Can I say that your chief executive has been absent?
The last
You know, and it's chief executive, and the big issue for me also is you've lost the chief executive of the Belfast Trust, who was a first-class operator. Now, you've got a very good one in, I'm quite sure, on a temporary basis, but I couldn't believe that Colm Donoghue was allowed to go. And now, when you look, and without getting into personals, you look at the Southern Trust and you're in the same boat there. How are you going to manage this? It seems to me that if the board is supposed to be there to support the trust, you can't keep dropping the ball here.
Well, the chief executives of the trust is not a matter for the board.
No, but you have a duty to support them.
And I believe the board is fulfilling that duty. The board is working very closely with all of the trusts. You started your question around what are some of the things that need to be done, and I think during the course of the session we've touched on a number of those, and certainly there is considerable work still need to be done to put in place the alternatives, and that does require funding to be able to put in place those alternatives. There are still things that need to be done to make the system more efficient and work better, and the board is working with trusts in relation to that. And then some of the other measures that have been identified through the task group, such as the ones I touched on earlier about broader 7-day working across a range of services. So the board is currently working with each of the trusts through the local commissioning groups currently to bring forward detailed proposals as to how we will actually put those broader 7-day services on the ground over the next year. But again, that will be subject to funding.
Just very briefly, I know Charlotte will pick up the workforce issue, and again, it is back to Fergal's point earlier in terms of policy direction in this. I mean, someone much wiser than I once said that every system is perfectly designed to get the results it gets, and I think it is about that wider transformational piece in terms of how we transform the model of health and social care in Northern Ireland, and the strategic direction, the policy direction, you're quite right, as you alluded to earlier, is outlined within transforming your care. And as I said, when I last gave evidence to the committee, that large-scale system reform takes time. We are 3 years into that journey. Could we be further down the track? I think yes.
We used to call it shift left.
We're all
So you're longer than 3
We're
years.
all frustrated by the pace of change and that new model, because it's a radically different model, Michael, and you know that, from the model that we currently have in terms of dealing with the demographic pressures of an ageing population, the financial and resource pressures in terms of doing that and providing that same quality of care, the same experience of that care at lower cost. But it's a completely different model. It's a model which requires much more investment in primary and community care. Again, the point Fergal made earlier, it's a model that actually changes the focus away from the acute sector. But that strategic direction will be impacted upon our ability to invest in those new models at the same time of building public and indeed important political confidence in those new models in that transition. And again, it will be constrained by the resources that are available to the health service in the years ahead. I mean, we've seen that already have an impact in terms of the changes that we would wish to implement. The Minister has made that point in terms of what he sees is going to be the dominant issue for health and social care this year. Again, you've had umpteen opportunities to talk to officials and receive evidence and question officials in relation to that. And I've also read the Hansard transcripts of your frustration around the pace of that change, and certainly it's going to be a very challenging environment over the next period as we seek to implement that in a very financially constrained resource environment. But on the workforce piece, Charlotte?
Yeah, I think Michael, in order to predict what you're asking us to look at, we have to really have robust workforce plans in place, and there has been a gap in terms of our workforce planning at the department. That's now hopefully, it has been rectified. The department have set up a regional workforce planning group, and they will be taking forward workforce planning in a multidisciplinary way, which hasn't been done before, by programme of care. So the first one we're going to look at is primary care. In advance of that, we have done uni-professional workforce plans. So the nursing workforce plan has just been completed. Over the last few years, there's been a reduction in the number of nursing places trained at Queen's. The recommendation is now that we leave them the same, as not to reduce them any further, to leave them as is. And that we target particular groups of the workforce to support the change that needs to happen in TYC. So we look specifically at how we can look to promote new roles, extra staff in the community. The district nursing teams are working very hard with complex cases, much more difficult and complex care in the community now than there would have been even 5 years ago. And the sorts of care that's been provided in the community simply would have been provided in a hospital environment in the past. And I think we need to recognise that in terms of skilling up our workforce. So that workforce review is in its final stages. It will go out for engagement and consultation subject to Minister's approval. The medical workforce review, I'm not as close to it, but I know there has been cross-cover between it and the nursing one in terms of sharing roles, taking on different roles and supporting each other, particularly in the areas where we know we've got traditional difficulties, for example, around ED and emergency care. It's a team approach, and we need to utilise the best skills within the team, regardless of the professional background of the person. And we have developed a programme around advanced nurse practitioners to support our colleagues in emergency care. I think that same model could be used in primary care to support GPs in practice. I don't see any reason why nurses with advanced nursing skills couldn't be seeing, treating, prescribing and discharging patients on behalf of the GP if we find a way to make that work. I think urology is another example where we have difficulties with consultant-led care, where nurses can support the consultants to do the most complicated work, and the nurses could take on a higher level of skill in a contained way, using protocols that would support the consultants to work at the very urgent and the very complicated work. So we're looking at all of those things, and no doubt that will have to be factored into what is a very difficult financial situation. We can only use the money that we have in our budget, and trying to meet these needs in that difficult environment is difficult.
And the same applies to medical workforce. I mean, we touched on this earlier in relation to primary care. I mean, we know the shortfall that we have in relation to GPs per head of the population here in Northern Ireland. So there's a specific work stream looking at what we will need in primary care. And I know you've taken evidence from the Royal College of General Practice in the past in relation to their concerns around the resourcing and indeed the numbers of general practice in particular. And there are areas around workforce where we need to invest. Everything, if we look at, we talked about diagnostics earlier, we're doing a major imaging review, and there are major workforce implications there, both in terms of, both consultant radiologists, but also in terms of other skilled members of that team who and other roles that they can be taking on. So there are major workforce issues.
So much can be done. You need to invest in people, invest in equipment, and also invest in buildings. Could I just ask you, as far as emergency is concerned, I know the Ulster, the work's going through at the minute and we'll get a new A&E out of that, as well as the ward block and all the rest of it, 190 million. Guess who signed that originally? The other one that I signed for was the Royal Victoria and the critical care building at 150 million. And it was anticipated to be ready, I think, about a year ago. I know you've had construction problems in there. Can we see that being resolved? Because it seems to me if that building, with all the gear that's going into it, is in place, it'll ease some of the burden. It'll not solve the problem, it'll ease some of the burden of the staff in the Royal A&E.
I think you're right. I think if we look around our ED departments, we look at Altnagelvin and the ED department there. It's a very constrained environment for committed, dedicated staff who are working, from patients to be looked after. And if we look at the ED department in the Ulster Hospital, yes, the new build there will be a huge asset. And similarly, if you look to the RVH and the ED department there, again, it's temporary accommodation. And the new building and the new emergency department will be a huge boost, I think, both in terms of morale of staff, but also in terms of improving patient flows and improving the patient experience in that. So it's hugely important. I understand they're working through, I understand those are, I'm not aware of the, as Chief Medical Officer, I'm not aware of the details of those discussions. You're right, there have been some difficulties. I understand those have been worked through to resolution. And I understand within the next number of months those will hopefully be all resolved.
Okay, thank you, Michael. George?
Chair, can I thank the team for their presentation? Absolutely excellent. As well as that, can I thank all the health workers throughout Northern Ireland for the magnificent job that they do. I've been in hospital several times and I just could not fault them. And the care that I've been given is absolutely excellent. Thanks to yourselves for making that happen. Now, my question would be around the city hospital. I know you've said that there's been a 32% reduction in the A&E service since last December, from last December to this December. But maybe just on a temporary basis, could the A&E, the city hospital's A&E department, could that not be opened even on a temporary basis during the peak winter months? December to February, roughly. Is there staffing problems still existing there? Or?
Well, if I could, and Charlotte would want to comment as well. I think we need to remember that the decision made by the Minister at the time in relation to the Emergency Department of Belfast City Hospital was in relation to concerns around safety of that service. And what it enabled was a concentration of services then on the other sites. I think it is fair to say that one of the important findings of the RQIA review on pages 21 and 22 of that review was that the closure of the Belfast on a temporary basis of the Belfast City Hospital ED department was not and did not precipitate the problems in relation to the RVH ED department last winter. And indeed, if you look at the figures, and I think Michael will be closer to the detail of this, that problems there last winter were not related to a huge spike in emergency attendance, quite the opposite. Quite frankly, those issues and concerns in relation to the safety and the ability to staff at an appropriate level, the Belfast City Hospital side, or to take the sort of approach that you've suggested as a consideration, would only but have compounded some of the difficulties that the Royal Victoria Hospital Emergency Department would have faced, or indeed the Mater Emergency Department would have faced over this period. It wouldn't have been of assistance. It actually would have diluted the number of very expert nurses and doctors available to provide an appropriately resourced and functioning service. I don't know if you're trying to want to add to that.
Well, I just think we need to maximise the resource that we have, and we have a group of very skilled ED practitioners, and we need to ensure that they're working at the top end of their game in the most difficult circumstances, supporting each other both through the urgent, the emergency and the minor injury unit. And I think it would be difficult actually to staff that up again. It would take a long time. It wouldn't be possible to do it in the foreseeable future. And
certainly
we
short
would,
term, yeah.
It's not to say it's impossible. I don't mean that, but it would take so long to staff it up and get it ready for the time period that you're talking about. There's too long of a lead-in time, and it would dilute the resources on the other ED sites, and therefore you couldn't treat the rest of the EDs with the same volume of patients.
Sorry, as I did mention, just basically on a temporary basis. I mean, last winter and this winter has been fairly mild, and we're only into January yet, and I'm sure there's going to be future pressures on our A&E departments. And I'm just thinking on that, even for next year, if the task force could even look at it.
Well, when the board, as you know, has completed a piece of work in relation to the pattern of emergency service. I mean, one of the recommendations within Transforming Your Care was that, and I think that, I think one of the there's been no decision made by the Minister in relation to the future of emergency department in the Greater Belfast area. But I think one of the lessons that we have learned from other jurisdictions, internationally, is the fact that it is about ensuring that we have the right degree of local services supporting patients with long-term conditions, but that when you've got really specialist services requiring emergency department care, what is crucially important is that you concentrate that expertise to get the best outcome for patients, and at the same time make sure that the transfer time and travel time for anyone is not excessive, that it actually compromises their care. So I think that whilst the suggestion, like all suggestions, is not something which we should be rejected. I honestly don't think, if we look back to that period, we certainly would not have had the capacity, quite simply, or the time to take that step. And to be perfectly honest, I think it actually would have, in my view, in terms of the work of the Unsheltered Care Task Group, I think, as Charlotte said, it would have compounded the problem rather than eased the problem. I don't know, Michael, from...
No, well, I think maybe just to add, as we've outlined a number of times this afternoon, one of the areas where there is still the need for action, the need for progress, is the move to much more 7-day working, extended day working. That is more difficult, the number of sites that you spread that across. If we need our physicians to be reviewing every patient who's in a bed twice daily, 7 days of work a week, it is easier to do that whenever those resources and those skills are concentrated in an area. Certainly, again, just to pick up something that I think Dr. McBride said, that the day last year, whenever there was the major incident in the Royal, that day and the preceding days, it was not about the number of attendances coming through the front door of the Royal. It was about a number of consecutive days in a row before that were particularly low number of discharges, and it reached the point where that caused those pressures. The number of patients presenting at the Royal on those days were within the expected levels, and the modelling following the temporary closure of the City Hospital on a basis of how many patients would move from the City to the Royal as opposed to the Mater or the Ulster or indeed to some other areas. It was planned for on that basis, and the numbers presenting were in line with that.
Thank you very much.
Okay. Do you still want to comment on
sorry,
the point?
I mean, you made the point about the spike surge, whatever it was last year, the shut of the city. I mean, the city shut 3 years before, and there was an increase in the Royal Victoria Hospital as a result. So it may have, by the virtue of the increase that was generated.
It wasn't a finding, it wasn't a conclusion RQI reached, but
Can I just touch on one other thing, because it is linked to these things in terms of community provision. I hope I'm not. Has everybody else asked all the questions?
No, I've still to come in, but you go ahead.
All right, just one thing. As CMO and not as CEO. How does the sudden announcement of the closure of nursing provision at Orchard House in East Belfast be consistent with the need for nursing provision in the community?
Well, I mean, that's probably something that Charlotte's better able to respond to. I think that I'm not familiar with all of the details of that particular decision or what informed that decision, but I think that I think there are a range of factors which impact on such decisions. One is around often the type of service. In many instances, speaking generically, it may well be following reviews by the QA in terms of the appropriateness of the service, the appropriate of the environment providing that service. Generically speaking, it also, in some circumstances, there are decisions, as we've said before here at the Health Committee, and indeed the Minister previously indicated there are some decisions which are made in relation to the contingencies that the service has been in a situation where it had to make in terms of living within locations. I don't know the specifics of that particular case as Chief Medical Officer, so I'm not really in a position to provide any greater detail. I don't know, Charlotte, if you're
I don't have any detail on it, Fergal.
Rather than scan around for an answer, I'd sooner maybe we'll communicate separately about
Okay.
this.
Sure.
Okay, that's grand. Perfect, thank you for that, Fergal. I just want to finish off looking at any services and looking at various issues around the problems that we have in NEs. And I kind of, well, I don't know whether I agree with it or not. I am on a 5-year career break and could end up back at Antrim Area Hospital in in a year and a half's time. So we're looking at 7-day working. I know that will then I'll be voting to be doing that myself if that's the case. But I know before I left in 2011 we had already started that in the social work department. It was already happening in OT and physio and other things. And then did you say that you're looking at radiography as well?
Yeah, radiology. I mean, look, as I think it was said, patients get 6-7 days, 365, and to be able to respond to that, back to the point that Michael made earlier, we need the service configuration, the service model, and the workforce to actually.
And we know it's not just A&E, because we know to discharge a patient out of hospital, which then frees the bed for the A&E patient. We then need community services in place for weekends. So it is a bigger piece of work. That needs to be undertaken. When we look at the other issues to do with A&E, to do with some of the problems surrounding it and some of the users of it, we know that our A&E is free to everybody. It's open 24 hours a day. Anybody can come in. We don't stop anybody from coming in. And I'm going to be really controversial now. Have anybody ever looked at that? When I talk about people who are abusive, under the influence of alcohol or drugs, what do we have any specific procedures around that? We do to protect. We have to protect staff. We have to protect patients.
Well, 2 comments very briefly, and then Charlotte, maybe you can talk to the detail of the work that we're looking at in relation to alternative models for patients who've consumed too much alcohol and maybe have some minor injuries. That's very disruptive, not just for staff, but also for other patients who are in the emergency department. But there's a zero tolerance in terms of verbal or physical violence to staff in all our hospitals, and that's the department's policy, and all trusts have policies in relation to enforcing that, and we will pursue that, and Michael Morning is very familiar with the detail of that. We will pursue prosecution where indeed there's a case in relation to anyone who.
What would happen then, Michael, if there was a prosecution or there was?
Well, there have been
staff. Is there an order then put out that that person cannot attend?
Well, indeed, there is a zero tolerance. We have regular rounds by security teams into emergency departments, and there's a zero tolerance of any behaviour where indeed there's abuse, verbal or otherwise, of staff, and indeed trust will seek to press charges and to the full rigour of the law where that is practically possible. In relation to people's use of ED, certainly that is something that we are looking at in terms of whether. I talked earlier about the diversion away from ED. We do know that we've more to do in terms of points I mentioned earlier in relation to Kieran's question, or Fergal's question, which is about educating people about alternatives and providing viable alternatives in the community and primary care, and informing their choice. Now, I did a lot of work in the run-up to Christmas with the Self-Care Week, which was launched by the Minister back in 19th of November, and Choose Well campaign. There's more we need to do there. But certainly, there is undoubtedly a significant number of patients who still use our emergency departments where, for a condition which they already have attended their general practitioner for, that may have been, they may receive an ongoing treatment and care and advice from their GP, and at this present moment in time, those patients will still attend ED and still will be seen by doctors and nurses there. I think we do need to have a conversation about better educating the public and making some decisions around how we inform patients that actually you may have attended an emergency department, but this is not the most appropriate place for you to access care. In that discussion, there's been all sorts of proposals around charging. I certainly, ultimately, those decisions are matters for a minister. I personally, as Chief Medical Officer, would not support such an approach. I do not want any situation where anyone feels that because of their ability to pay, that they're discouraged or dissuaded from presenting to any contact with the health service because of their ability to pay. In relation to the specific issue around alcohol, there is work we're doing.
Yeah, the out-of-hospital group of the Unscheduled Care Task Group have been asked specifically to look at putting forward proposals. So there is a model developed working with the voluntary sector and the police to look at developing the work in Shaftesbury Square around the bus there that looks after people who are intoxicated, particularly at the weekends. We'd like to try and extend that to provide some minor injury cover to that, and to pilot that and see what the outcomes of what difference does it make both to that group of clients and to the emergency department, and I think that can be done in a fairly low cost way. The other thing, just to, in support of what Michael has said around the number of people, I've been talking to the nurses who are often the first person who the patient meets when they come into the department in that triage role, about how they would begin to use protocols to redirect people to the most appropriate service. That requires us to actually have alternatives to the ED in place for that to happen. But there is work in other countries, and I would point to Scotland in particular for the work that they have done, and we're looking closely at that in the Unscheduled Care Task Group.
You can maybe a bit more detail.
Yes, just to add, the board is finalising a specification for that pilot service currently, with the aim of having a pilot service in place by March of this year, and that would focus on diverting patients who otherwise would have presented at the Royal and Mater emergency departments, offering a minor injuries type and sobering services for patients who are under the influence of alcohol. Obviously, it's essential that such a service has robust governance arrangements put in place around it, so work's going on with the ambulance service and others in relation to that, but our aim is to have a pilot service in place by March.
And we've been tasked by the Minister specifically to, it's something that he has heard from his visits to the emergency departments on the run-up to Christmas. As you know, he's been out and around all the emergency departments, and it's something he's heard from staff, and he's certainly heard from those using the service, and certainly something he's tasked us with looking at options. We're looking at models which are available in Wales, for instance, where there are similar services. But then the point here is that we will not compromise the safety of patients, because you will also be familiar that sometimes those who presenting to our emergency departments under the influence of alcohol can also have significant health issues. They may have fallen, they may have injured themselves, they may not be terribly coherent in terms of the ability to give a history, and their safety is of paramount importance as well. That behind the alcohol often can disguise some serious health issues which need to be addressed, and we will not compromise the safety of those individuals in any shape or form.
Mickey, you want to
I
come?
was just on that point, the sort of filter system, because obviously there's a number of people present with quite serious mental problems.
There are.
And they may be alcohol related or drug related as well. It's maybe trying to work out some kind of a filter system. They genuinely need help or otherwise.
There's been quite a lot of work done in emergency care in relation to mental health, and
Because A&E isn't the best place for them.
It's the wrong place.
It's the wrong place. There is a pathway. There's psychiatric liaison support, and alcohol liaison nurses working on those with those particular groups. There's also the Card Before You Leave scheme. There are a number of initiatives that have been put in place to support that particular group of people.
Okay, everybody. Yep. Thank you.
Thank you very much.
Thank you.
Thank you.
Okay, members, I don't think we'll take too much longer. If you can just bear with us, we've only got a few items left. So if I can turn your attention to item number 12, which is matters arising. I want to inform you that there are 10 items under matters arising in the meeting folder, and in the interest of time, can I draw your attention to several of those items? The first of those is item 12.1. Is a legislative consent memorandum relating to the Westminster Health and Social Care Bill. The bill will bring in regulatory measures which will also extend here to help regulators respond more effectively in fitness to practice cases. This in turn should help contribute to public confidence in the professional regulatory system. The committee took evidence from officials on the 5th of November and we were generally content with the proposals. The next stage for us is to formally consider if we are content to support the Department in seeking the Assembly's endorsement of the legislative consent motion. Before I put the question, are there any issues from members want to raise on this? No, if not, I then put the question to you, and is that the committee is content to support the Department in seeking the Assembly's endorsement of the legislative consent motion.
Yep.
Can I advise members that it is normal practice for committees to produce a short report on their consideration of the legislative consent motion, and a draft report will be considered at next week's meeting. Okay, and I move on to item 12.2, and it's a response from the Minister regarding the physiotherapy self-referral project. The Minister has advised that the proposals have been delayed rather than halted. Can I seek agreement to forward the response to the Chartered Society of Physiotherapy, who raised the issue with us?
Yeah, Chair, just to say that, express disappointment because we did raise this at the Health Committee and we got an assurance. I think we had it in the bag, as it were, and suddenly we'll get this here that it has not been, and it's been deferred. So maybe a letter back saying that we fully support the proposal from the physiotherapy and look to see a quick implementation of the self-referral programme.
I know when it first came out, we had been told it had been stopped, but the letter from the Minister said it's been delayed rather than halted. So,
Well, we remain concerned. We want to see it implemented as soon as possible.
Okay, thank you, Chairman. Okay, item 12.7 is a response from the Minister regarding Stephen Agnew's Private Members Bill, the Children's Services Cooperation Bill. Clause 4 of the bill proposes amendments to the Children's Order 1995. The Department is seeking legal advice on the proposals and is also consulting with the Children and Young People Strategic Partnership for their views on the matter. The Minister will be meeting Mr Agnew to discuss this further. Can I suggest that in the meantime we just note that at this stage?
That's right.
Right, go ahead,
Just in relation to that, wasn't the mental capacity bill, wasn't the children's order for 1996, wasn't it to be looked at in terms of the capacity for under 16-year-olds? And me says
There, from memory, they would need to go back and check the papers, but there was a group set up to look specifically at a project at the under 16s issue. I would expect in the next few weeks the two departments to publish the outcome of the public consultation on the mental capacity bill. So I would presume that some of those issues, the most up-to-date position would be in that paper when we receive it.
Thanks.
Okay, members, can I move then on to agenda item number 13, which is correspondence. And there are 17 items for correspondence in the meeting folder. And in the interest of time, can I advise members that can I draw their attention to several of the items. Firstly, item 13.12 is a letter from the BMA regarding the consequences of the Chancellor's autumn statement regarding funding for GP services in terms of any new monies available here. Can I seek agreement from the committee to write to the Department to seek their understanding of this position?
Great.
Okay. Item 13.13 is a letter from VOIPIC requesting a meeting with the committee to discuss their report, Our Life in Care. Can I seek agreement to invite VOIPIC to the next stakeholder event?
Great.
Thank you. Item 13.15 is a letter from Genomic Health seeking a meeting with the committee regarding the commissioning of a particular breast cancer test. Can I suggest that the committee writes back to the company to advise that it does not become involved in the procurement arrangements between the Health and Social Care Board and companies, and suggest that the company should continue to liaise directly with the board?
Just on that, I had a correspondence and an email from, it's actually one of our ex-GPs who has unfortunately developed breast cancer, and the oncologist, you can get a test which determines whether you need chemo or not. And I know there's other correspondence in about that, but it seems because she was able to pay for it basically, it in the long run probably does save money, because chemo, not only is it expensive, but it also can be detrimental to other aspects of a person's health. So while it's curing one thing or helping one thing, it may well be affecting internal organs and all sorts. So it just seemed, and I mentioned it briefly to the Minister, I have to say, because I happened to meet him. He was saying, well, then you might have to introduce it for everybody, but I think it's something, apart from the commercial aspect of it, I think from a patient's point of view, it's worth maybe exploring, because the information I got was very detailed, and obviously it's coming from someone who knows, highly qualified, and has a fair idea of what they're talking about.
I would imagine is there only one company that makes this or does this?
Chair, I think we could look at this in the narrow sense of commercial deal between this company and the board or whoever commissions it. But in reality, it's new treatment, and it's about innovative medicines, and it's about actually saving money, as Mickey quite rightly points out. So yes, we could reject them on that basis, but I think there are other issues there that are of interest to us, particularly after our visit to the Cancer Centre and the evidence from David Waugh about this is the very, and while that might be jobs and enterprise and development stuff, it also has a health focus, and we can't ignore that.
And I understand that, but when it comes to a company, we can't be there to recommend a company either.
No, we're not recommending it, but I think we need to inform ourselves.
We don't know enough about it as a committee.
To know more about it.
Yes, but we
could have seen on a personal level, as somebody who's lost a wife to breast cancer, only 6 years ago almost, tamoxifen was only coming in as a drug then. It is now used as a preventative. So the progress in the fight against breast cancer has come forward tremendously. And there's a lot of women who probably, if they don't need chemotherapy, it's given again as a precaution, I suppose, and sometimes can have a detrimental effect, as I said, on other aspects of the health, which if it isn't necessary, you can survive without it, then the test can actually determine that in most cases. So I agree with what Fergal's saying at a commercial level, but then again, if you look at the whole issue around getting the drugs, generic drugs, the patent has to run out. There's also all sorts of issues around that. I think it's worth maybe exploring.
This is a new type of diagnostic, and it's the future. Personalised medicine is the future.
And we have heard from other companies that are offering local companies of diagnostics that we don't do here, but other parts of the world do.
Yeah, it's the type of thing I think we should inform ourselves more about. Now, I wouldn't like to see the commercial thing being a hurdle to us hearing about what genomic medicine.
Catherine has a suggestion.
Yes, Chair, I was just going to suggest that maybe the committee in the first instance could write to the department to ask what is the policy in relation to looking at innovative tests for breast cancer.
Yeah.
But even beyond breast cancer, because there are other tests available for other types of, but it's just maybe in general to see, and we can take it from there then.
But one of the things that came up in terms of the Strep B going back a few years, that was fairly innovative and it wasn't always done. But again, on a personal level, my daughter-in-law was about to have her baby, and when she asked for the Strep B test, it was positive. So if she hadn't, it could have had a detriment. So you do pick up these bits of knowledge, I suppose. But what I'm saying really is it should be from a patient aspect as opposed to any commercial. It's for the benefit of the patient. It has to come presumably from somewhere.
Okay, and I do agree with you, and I do think there are many other diseases as well as cancer that there are available that science is the technology we have.
It's racing ahead in our processes, and we've even heard here today, a lot of our processes spend an enormous amount of time trying to catch up and find themselves lagging behind. And that doesn't mean that we as a committee need to lag behind. We can investigate and look at these things, in a much easier way.
Okay, all right, members. Which one are we on? Item 13.16 is a letter from the Creative Local Action Group requesting a meeting with the committee. Can I again seek agreement to invite them to the next stakeholder event?
Agreed.
Okay, members, I draw your attention to item number 14, which is the Forward Work Programme, which is in front of you as well. Can I ask that the Forward Work Programme be considered at next week's meeting, based on our earlier discussions at the planning meeting? And also there will be a briefing next week from Pubs of Ulster in relation to the Food Hygiene Rating Bill. Okay, members. Any other business?
Chair, just members got, I have it in front of me, a letter from a gentleman, the Reverend Paul Erskine.
Okay.
Have you not seen it? No. Just drawing our attention as members of the Health Committee to the fact that the Department of Health has reduced their budget. They provide spiritual things. Yes, that's right. From 60% down to, well, from 64,000 to 20,000. There's a big gap, and obviously the service that they provide will be hindered. Is there anything that can be done? I mean, I'm sure we have sympathy with what the Reverend's saying, but I don't know if we can do how much about it.
I don't know if we can as a committee. We can as individuals, though, when it comes to writing to the Minister. I think as a committee, though, they're not employed directly by the Trust. They're not Trust employees, albeit, yes, I know that they do an invaluable job.
Yeah.
I know that myself. I've worked with them. And it is a shame to see that their funding has been cut, because for some people that is their lifeline, and the only people they get to see other than the staff is the chaplaincy service as well. So it might be up to us as individuals rather than as a committee to
Could we
I think
record our disappointment?
I think we should. I mean, the figures there, so I'm just looking at Kieran's paperwork, there's been cut from 48,000 down to 20,000. And given the role that they play, and that's spread out among a whole range of chaplains.
Just to record our disappointment.
Yes, I think we can do that, and I do think it's incumbent on us as members
Right,
to do it, because it is a valued service.
Absolutely.
For many people. Pam has left me a note also about it was on part of our correspondence, I think, but I didn't look it up in time. It was to do with the letter that came to do with Huntington's disease on page 142, and it's regarding the funding for 2 nurses, band 7 and band 6. I think some of the members were at that business or the breakfast that they had, and she had said that the band 6 post was re-advertised again on the 9th of December 2014, but they haven't been able to find.
I know, I mean, I think we should be asking more questions about that. They're saying they're having difficulty identifying suitable candidates. You know, what's the detail? What's wrong there?
I know it is, and as Marie said, it's a specialist field and all of that, but it's band 6, it's not band 7 as well, so kind of thinking, why are they not getting, what is the reason as to why they're not getting people applying for this? I would imagine that there would be quite a lot of nurses that would feel that is the area that they would want to work in. But we maybe just need to keep an eye on it over the next coming months, so we could maybe even, I don't know, just find out actually why.
Seek to reduce the criteria or something?
I actually tried to put in an oral question asking for more information, and I was knocked back on the basis that I'd asked a question about it within the last 3 months. So.
Well, then we could, Catherine is just saying, suggesting that we could maybe ask about the recruitment process.
Chair, if it was only advertised on the 9th of December, a closing date is probably for, submissions would have been the end of December. So you could get an update of whether anybody has actually applied for it. Or if they release that information, because there may be HR procedures around it. So.
Okay, everybody happy enough? Any other business? No? Okay, members, thank you. Date and time of next meeting is next Wednesday the 21st, starting at 2 p.m. in the Senate chamber. Thank you. Thank you.